Namaskar and good evening, everyone. I welcome you all on the second day of third Best Clinical Oncology Symposium Recent Clinical Updates. And with immense pleasure, I would like to invite Dr. Jitendra Paheljani, who is Consultant Medical Oncology at CG Cancer Center, Jaipur, for the welcome and introductory note and to carry out the further proceedings. Over to you, sir.
Thank you so much for a nice introduction. It's been pleasure to associate with the Horizon conference, and it's uh, very enlightening to listen to the lectures till today. And the today's agenda of this session will be breast cancer. As we all know that breast cancer is one of the most common cancer in female and in other cancer subset also it is number two cancer in world as well as in India. So it's an important domain to understand with the current understanding of our for this malignancy. As we know that we are having newer data coming up day by day, so it's always enlightening to listen to the experts how things goes, how the targeted therapy, immunotherapy, and anti-HER2 therapy is changing the domain. So it will be an interesting session to understand how we can best use these drugs in the current time. So I would like to start the session with the first topic by Dr. Jyoti Vadhva. She is a Director of Medical Oncology and Hematology at Medanta Medicity, Gurugram. And I will hand over the mic to Ms. Dr. Jyoti.
Good evening, everyone. Thank you, Dr. Jitendra. May I share my screen?
Yes, ma'am, you can.
Okay. Are these slides visible now?
Yes, ma'am.
Yes, ma'am. Just make it full screen, ma'am.
Yeah. Okay. So this talk has been sponsored by Novartis. It's entitled Core Phase Results from Complement 1, which is a Phase 3B real-world safety as well as efficacy data of ribociclib. We all know that CDK4/6 inhibitors have revolutionized breast cancer treatment, and ribociclib has emerged a winner, in fact, since this is the molecule which has also documented improvements in the overall survival. Breast cancer patients, almost 3 out of 4 of them do get diagnosed with hormone receptor positive subtype. And a lot of these patients, in fact, have metastasis at diagnosis. Almost 60% of the patients have de novo metastatic disease. And 2/3 of these patients have visceral metastasis. The median time to progression now is to the tune of 8.4 months from the first line treatment. And a lot of these patients, even though they are hormone receptor positive, they still get treatment with chemotherapy. We know that chemotherapy is a clear-cut option when they are in visceral crisis. However, in reality, we know that even when the patient is not in visceral crisis but has visceral metastasis, we do offer chemotherapy to some of these patients in our real-world practice. So in the first-line treatment of patients with metastatic hormone receptor positive HER negative disease, as I mentioned, despite guidelines contrary to what we practice, patients are being treated with chemotherapy in the first-line setting also. Many of the patients who are presumably of poorer prognosis, such as those with visceral metastasis, those who have CNS metastasis in particular, often get excluded from the clinical trials. The clinical trials are often limited to patients who have good performance status, and these trials frequently exclude patients who actually belong to this poor subgroup. So this study was undertaken called Complement 1 study, which was following a large cohort of such patients in real world to evaluate efficacy and safety of the molecule ribociclib for advanced breast cancer. Now, to be eligible for this study, the patients had to be treated with 1 or lesser lines of prior chemotherapy. The patients could be both pre or post-menopausal. but had to have no prior endocrine treatment for advanced disease. They had to have stable CNS metastasis and ECOG performance status of either 0, 1, or 2. The primary outcome was measured with the frequency of adverse events, frequency of serious adverse events, and adverse events of special interest. Now, the patients in this study, they received ribociclib in the standard dose, 3 weeks on, 1 week off, along with letrozole, again in standard dose, continuous daily schedule. And if they were pre or perimenopausal, they received GnRH analog with either goserelin or leuprolide, both in form of monthly injections. The treatment was continued until disease progression or unacceptable toxicity. Now, there were 3,246 patients included and studied between November 30, 2016 to March 2018. The median duration of follow-up was 25 months and minimum follow-up was for 19 months. Now, 40% of these patients actually went on to complete the core phase treatment, and a lot of these patients, almost 400 patients, moved on to receive the extension phase of this study also. So if you notice carefully, this real-world complement study included a diverse population of patients, very heterogeneous, very similar to what we actually deal with, patients who had CNS metastasis, patients who had ECOG performance status 2, and even patients who had received chemotherapy for advanced breast cancer. So if you notice here further, a lot of these patients were 75 or greater years of age. There was a representation of a diverse race, ECOG performance status, as I mentioned, even up to 2. A lot of metastatic disease sites, 43% of patients having 3 or more metastatic sites, patients with visceral mets, CNS mets, and even those who received chemotherapy for advanced disease were part of this cohort study. What did the results from this study show? A lot of these patients had, all grades adverse events, and some of them had serious adverse events, but the adverse event profile was quite manageable, and there were no new safety signals identified basis this real-world evidence. They were quite similar to what had been reported in various trials. And furthermore, it was noticed that as the duration of treatment with ribociclib got prolonged, lesser was the frequency of various adverse events, namely neutropenia or transaminases, or even frequency of QTc prolongation. Now, the median time to progression in this study was 27 months, which is in fact quite comparable to what has been reported in various clinical trials. The overall response rate of the total population was 29%, and the response rate in patients with measurable disease at baseline was 43%. The clinical benefit rate in the total population and also in those with measurable disease was to the tune of 70%. So if you notice here, the response rates in fact seem a bit better compared to what has been reported in the clinical trials. Furthermore, ribociclib maintained an overall good quality of life in the patients as well. So to summarize the primary endpoint, the rates of all grade and grade 3 or greater adverse events were 95% and 67% respectively. Treatment discontinuation rates were 12% due to all grades and 7% if due to grade 3 or greater adverse events. The median time to progression, as I said, was 27 months, and the quality of life was maintained. So these results, you would notice, are quite similar to what has been reported in the clinical trial setting. Now, furthermore, if you notice, ribociclib had exceptional subgroup consistency. So there were these 5 subgroups which had been identified in this cohort study, namely patients with CNS metastasis, patients who had received prior chemotherapy for the treatment of advanced breast cancer, patients with ECOG performance status 2, patients with visceral mets and going on to get prior chemotherapy, patients with visceral mets with performance status of 2. So if you notice here, all the patient subgroups experienced quite fewer adverse events compared with the overall study population. So nothing worse happening here, even though classically these are the well-known poor prognostic subgroups. Now, in patients with CNS metastasis, we have hardly any data from the phase 3 trials. There's a phase 2 study of abemaciclib, which did include patients with CNS metastasis and hormone receptor positive advanced breast cancer. There was this real need to look at the data of the efficacy of these molecules in those with CNS metastasis. However, many of these studies, the phase 3 studies also have been excluding the patients with CNS metastasis. So in this cohort study, the time to progression was better in the CNS metastasis group. In fact, time to progression, the median was not yet reached in this subgroup during the study period. The overall response rate and the clinical benefit rate in the CNS metastasis group was quite similar to the overall group. So if you notice here, the blue bar saying the overall group, the all patients, and the red bar showing those with CNS mets, you would notice here to the right of the slides, the overall response rate very similar, and the clinical benefit rate is also very similar. The time to progression is quite comparable even in those who had prior chemotherapy used for their treatment, so 18 months and almost 14 months. Those with performance status 2 also fared quite well with the use of ribociclib. In those with the performance status 2, the median time to progression was 19 months or 18.8 months with the use of ribociclib. If you notice, the black bars show the overall group of patients, and the different colored bars show those 5 identified poor poor prognostic subgroups. The patients with CNS mets, those with prior chemo, performance status 2, visceral mets with prior chemo, and visceral mets with PS2. So if you notice, the heights of these bars are quite similar, showing thereby that the results were consistent. There was consistent overall response rate, and clinical benefit rate was quite similar in all these subgroups, and though a little less than the overall overall set of the patients, but they were still quite significant, meaningful, and quite similar. So to summarize once again, the safety results consistent, no new safety concerns raised, time to progression in those with CNS mets consistent with the overall study population, and each patient subgroup, those 5 subgroups, achieved a meaningful clinical benefit from the use of ribociclib. So in fact, we can say and we can conclude that real-world experience does mirror the randomized control trial data. And herein you can see what we saw in the Mona Lisa trials, if efficacacy as well as safety, and the various Mona Lisa trials 2, 3, and 7, earning ribociclib the ESMO MCBS score of 4 and 5, the only molecule to get a score of 5 by ESMO in the magnitude of clinical benefit scale. So such benefit has been reproducible in the real world scenario also, and quite similar PFS and response rates. So takeaways from Complement 1 trial: this is the largest prospective database on ribociclib, and comparable, if you compare, this is largest compared to any other CDK4/6 inhibitor as well. Safety and efficacy data consistent, and it demonstrated consistent results for all poor prognostic subgroups, including those with CNS metastasis, and therefore supports the use of ribociclib with letrozole in first-line setting for patients with hormone receptor positive HER negative advanced breast cancer. So I would end my talk here, and thank you organizers for giving me this opportunity. I hope I finished in time.
Yes, ma'am, very crisp talk, and we are on time actually, and we will be obliged that you are on time. So after alluding with the CDK4 inhibitor, now the next thing which we have is the PIK3CA kinase, and to elucidate on that, we invite Dr. Pankaj Goyal sir, who is a consultant medical oncologist at RGCI Delhi, and over to you, sir.
Thanks a lot for inviting me for this session, and I'll just share my slides. Are my slides visible?
Yes,
Are
sir,
my slides-
visible. Yes, sir, visible.
Yeah, so I'll start the presentation just a minute. So, topic for my presentation will be picking the right strategy for patients with hormone positive or negative PIK3 mutated breast cancer patients. And we know that PIK3 is the most commonly mutated gene in hormone positive breast cancer.
Excuse me, sir. Sorry
Yeah.
to interruption, but I think आपकी slides के ऊपर ना ये icon आ रहा है या तो इसे आप side कर दीजिए.
Okay, I think
Yeah, perfectly fine, sir.
so 40% of patients with these patients of these hormone positive or negative breast cancers have this positivity for PIK3 mutation, and they carry a worse prognosis as per the data. And there was a lot of space for improvement in the outcome of these particular patients. And this is a poor indicator for the PFS and OS in these MEC patients. And this was the genomic analysis of 649 MEC patients and patients with hormone positive who have relapsed or progressed during endocrine therapy for less than 12 months after the end of endocrine therapy were analyzed. And also there was a meta-analysis of 1929 patients with breast cancer patients, and presence of PIK3 mutation was found to be a negative prognostic factor associated with poor response to therapy and worse overall prognosis. So we know that PIK3 is related to cell proliferation, tumorigenesis, which leads to poor prognosis, and also at times endocrine resistance, so that these patients have poor PFS on the first line therapies. So knowing the patient's PIK3 mutation status may guide us the upfront treatment strategy and response to treatment. What is expected from this? So there are selective inhibitors of PIK3, which may lead to hyperactivation of PIK3. We know. Sorry. Targeted PIK3 mutation may overcome the resistance to endocrine-based therapies used in hormone-positive subgroup of patients. And Pivicto, that is PIK3 inhibitor. Just a minute, I'm having disturbance in this. Fulvestrant basically works synergistically to inhibit both the PIK3 and ER pathways respectively. So SOLAR-1 was the first phase 3 trial leading to approval of specifically for advanced breast cancer who had PIK3 mutations. So this was basically for the second line treatment. A total of 572 patients were enrolled, and the patients were postmenopausal women more than 18 years of age, hormone positive, recurrence or progression on or after the AI therapy. So these were randomized to either fulvestrant alone in the standard dose of 500 mg day 1, 8, done day 1, 48, 28, and then every 28 days, or it was combined with Pivicto 300 mg daily. Primary endpoint was PFS, secondary endpoint being OS and overall response rate. So we could see in these patients, median PFS actually improved from 5.7 months to 11 months. So there was doubling of PFS in these patients when Pivicto was added to fulvestrant. So this happened to be a category 1 preferred option in NCCN in these particular patients. So there was subgroup analysis also done, and it was seen that the result was consistent across all the subgroups, whether the bone disease, visceral disease, and whether the patient had received prior chemotherapy in neoadjuvant or adjuvant setting, and whether few patients were also first line, and most of the patients were in second line. So this was favorable for all the subgroup of the patients. So more than double the response rate could be seen, and Pivicto plus fulvestrant, the response rate was 35.7% as compared to 16% with monotherapy. And also in the another analysis, it was 26.6% as compared to the 12.8%. So this was seen in the patient with measurable disease and all the patients as such. So tumor shrinkage was observed in 75% of the patients, that is 3 out of 4 patients who had a measurable disease. And the patient on Pivicto actually showed a deeper response, as we can see in this graph. So dosing, as we know, the starting dose is 300 mg daily, once with food, and this should be swallowed whole and taken with food at same time each day. Fulvestrant is used in the same day, and if the dose modification is required, which is required many a times, it is in the decrements of 50 mg, and it has to be continued till disease progression or the tolerance. So main side effect, if we compare it with fulvestrant alone, so basically it leads to more of hyperglycemias. If we see, it is as high as 37%. Along with that, fatigue was a bit more, 5.3 as percent to 1%. Diarrhea chances, transforming diarrhea was 6.7%, and skin and subcutaneous disorders were 19.7%. So basically, diarrhea, basically hyperglycemia and rash were the main problem with this drug. So we know that since the mechanism of action of these PIK3 inhibitors such that it leads to glucose increase, including hyperglycemia, and this is the on-target effect of PIK3 inhibitor because they act on the insulin receptors, and thereby they inhibit the uptake of glucose and leading to increased glucose in the circulation. So dose modification, if the patient is having grade 1, 2, 3, 4, accordingly, the dose has to be modified. If the sugar is within like less than 160, then no dose modification is required. And if it is 160 to 250, then we have to again add some OHs. Usually metformin is started. If not, that is also not taking care of it, then pioglitazone is added. However, if it is more than 250, then insulin may be used, and alpelisib has to be stopped till it comes to normal. And in patients with the patients who have very high glucose levels, again we have to first control the sugar levels, consult the endocrinologist, and follow the guidelines. Stop alpelisib, and after the patient has the normalization of alpelisib, usually these patients need to hold the drug. So, and after the patient regains the normality, this can be again initiated. So, also, it is very important when we start this drug, we have to first counsel the patient, educate the patient that hyperglycemia is expected. So, whatever precautions are to be taken in diabetic patient should be advising these patients beforehand, like proper exercise, limited intake of trans and saturated fatty acids, taking frequent meals but small meals, then low carbohydrate and low fat meals, and personalized that diet plan has to be given to these patients. And also these patients should be educated that they should be regularly monitored for the glucose levels, and they have to report if needed SOS. So the only laboratory monitoring needed for patients on this Pluvicto is fasting blood glucose and HbA1c. So initially the frequency of testing is once per week, and after 2 weeks it's at least once every 4 weeks, and HbA1c is tested every 3 months. And if the patient has hyperglycemia, then probably we have to test maybe twice or thrice a week, and then the frequency can be decreased. And after first 8 weeks, then it can be made every 2 weeks, the glucose monitoring. That has to be intense. And another issue was the rash. This was also taken care of by using prophylactic antihistaminics. So the patients who were given prophylactic antihistaminic, the chances of rashes decreased from 23% grade 3, 4 to half, that is 12%. And grade 1 or 2 rash decreased from 41% to 23%. So now what to test, when to test, that is a major issue. So it has been seen that testing of the PIK3 beta can be done in the initial tissue itself, because these mutations are there in the tissue to start with. However, if fresh sample can be tested, that also can be done. Now, other issue was whether liquid biopsy can be used. So previously, the guidelines used to say that we have to first do liquid biopsy and then we can do a tissue biopsy. But the latest update is that it's better to go for a tissue biopsy, if at all, to check for this PIK3 mutation, because the positive predictive value of this liquid biopsy is not that high. So to summarize, PIK3 mutations are present in 40% of these hormone positive breast cancer patients, and these specifically target PIK3 mutations. They double the PFS from 5 months to around 11 months when the combination is used. And this is also doubling of response rate, as we have seen in the previous slides. And safety information, we have to be careful, selective in the type of patients who are offered Pluvicto, and the sugar levels have to be monitored closely. Along with patient has to be told that rashes are expected, and patient has to report if any untoward symptom are noted like hyperglycemia or maybe increased thirst, or maybe dizziness and rashes. With that, I'll conclude. Thanks for that patient hearing. Thank you.
वो तेरा काम करना तो सब जगह तो हाथ मार जरा फाइल खोल दादा फाइल खोल
Hello, Dr. Jiten sir.
yes yes
Sir, can we
Yes.
request the next speaker?
yes so the next session is sponsored by Eli Lilly and that topic of discussion is cancer does not take a day off, then why should a CDK4/6 inhibitor? Since these agents are very effective, so it sometimes looks feasible to stop them the way we are planning to do with CML. But how we can do it to elude it, I will like to invite Dr. Bharat Vaswani sir, who is a senior consultant and medical oncologist at Yashoda Hospital, Hyderabad. Welcome, sir.
Good evening, everyone. Sir, am I audible, sir?
Yes, sir, you are audible.
Oh, so I'll let me thank the organizer, Somani sir, whom I consider as my elder brother, JP sir, TP Sahu sir, and Lily for giving me a chance to discuss. Probably now the thing what we want to stress in the next 30 minutes is the main first take-home message. I always discuss about what you have to remember that all these three drugs are different now, and we have already realized now we have a data of Paloma 2 available also, and I think the picture is now getting a bit more clearer and where to use what and in what circumstances. So probably in the next 30 minutes, if we can find out or we can make these points clear to you, that will be the main purpose of our discussion. The discussion I have with us with Dr. Alurkar sir, who will be moderating. Before that, I am just presenting the first case just to start the discussion about. So I am Dr. Bharat Vaswani, Senior Consultant Medical Oncologist at Yashoda Hospital, Hyderabad. Next. Now, this is one of the peculiar cases that few of you have heard, but probably one of those cases where you should remember that the drug has to be very specific in what you use with the data available at present to us. So let me first complete my case and then we'll have a good discussion. So this is one of my cases. 50-year-old female was diagnosed as 50-year-old as carcinoma breast right in June 2019. It was a T2 disease with multiple axillary lymph nodes. So as per as guideline, we gave 4 cycles of AC. It was a ERPR strong positive, HER2 negative. So as in view of locally advanced nature of the disease, we gave 4 cycles of AC followed by 4 DOSI followed by right modified radical mastectomy. As per this protocol, she completed radiotherapy in January 2020. I would like you to just to concentrate on the timeline because that is where the entire thing lies. So the treatment got completed in January 2020. She was ERPR strong positive. We checked the serum FSH, which was in post-menopausal range. So started on letrozole. Now 6 months down the line, in an interim normal checkup, she was doing fine. There was no problem. In January, that is 1 year from the start of this hormonal letrozole in an adjuvant setting, she presented with fatigue, exertional breathlessness, and upper back pain. Now, when we did a PET scan, it was basically, there were multiple mediastinal lymph node, paratracheal, aortopulmonary, subcarinal, and hilar. Now, in a country like India, first impression, we thought maybe it could be a tuberculosis, maybe. So we did an endobronchial ultrasound guided biopsy. To our surprise, it was a recurrence. So a strong ERPR positive recurred within 1 year. Now we rechecked the ERPR, it was still strong positive, 80% with all rate of 8/8. IDC Ki67 was 20%. So if I have to summarize the CA breast post-op, this is a primary endocrine resistant, and that is the first thing that I will like you to remember. Early relapser within 2 years of adjuvant hormonal therapy, or within 6 months of the start of hormonal therapy in the metastatic setting is called as primary endocrine resistance. More refractory patient, probably the patient with having a worse prognosis among all the patients. So the patient was explained about the nature of the disease, guarded prognosis and palliative intent of treatment. We did a baseline CBP, creatinine, LFT, 2D echo, and ECG, which was normal. Next slide. Now you can see the mediastinal lymph node. You can see in the in both the things there were lymph node, and she was symptomatic in terms of cough and breathlessness. Next slide. You can see the other views of the lymph node which were present in mediastinum, which were positive. Next slide. Now we all know that when we divide our HER2 negative and hormone receptor positive, so patient, basically every disease is not one. And how do we decide a good or a bad prognosis? So probably roughly we say these are the 5 parameters. According to me, the most important parameter which determines our prognosis is how fast the patient has recovered following a hormonal therapy. Second, presence of either a visceral or a liver mets. The few important things which I believe is equally important is a grade 3 tumor, a negative PR or a luminal B, and last but not the least, I will add on a younger or a premenopausal patient. So probably these six factors in isolation or in addition should tell us what is the best drug to use and probably how bad the disease is. Next slide. So this was a patient who progressed within 1 year of letrozole in an adjuvant setting, that is a primary endocrine resistance. So because I'll be discussing this all in the moderation. So all of us know that the patient has progressed on letrozole. So the best next now comes the scenario which I think we should be discussing in our moderation. Abema, Palbo, Ribo. When this discussion started a few years back, the main thing which I used to hear is, sir, we will decide based on the comorbidity. So if the patient has cardiac problem or a GI or a bone marrow suppression, I'll tell you this is not the way we should do it now, because now we have clear-cut data in a long run which tells us that this agent has probably a more effective or a more potent thing, and that is what we'll be discussing. So I am not going into discussion, but we started the patient on abemaciclib because, as we'll be discussing, the most potent drug among the three, apart from CDK4/6, there is a CDK9 and a CDK2 inhibition also, and probably these are the escape pathway in the primary endocrine resistance. And we have a very good data which is available in Monarch 2 with the best hazard ratio. So we started the patient. The CDK partner we chose was abemaciclib along with fulvestrant. Next slide. So she was given abema 150 twice a day with fulvestrant. Next slide. Now this is something that I just wanted to create a background. Now when you talk about Monarch 2 and when you talk about the main landmark, that is the overall survival, the quantum of benefit or the difference was 9.47. I would like you to remember the hazard ratio. It was 0.75. In fact, in Monarch 3 also, which was the first line, it is 0.75. Now, what was more interesting was the prime, please remember, this was a predetermined endpoint. So this was not an exploratory endpoint. So what they observed was in a primary endocrine, this hazard ratio was 0.68, better than the overall population, as against secondary, where it was 0.78. And when you look into the overall survival, it was 38.7 months. So both the things, a better overall survival, and more importantly, the hazard ratio of 0.68 in these refractory primary endocrine resistant patients. So better. Now we'll be comparing with others. Next slide. Now, when you talk about Paloma 3, probably unfortunately, palbociclib, which started with the first thing, has failed in the first line also with the updated data of Paloma 2. Please remember, palbociclib failed in this ESCO. There was a presentation. There is no improvement in giving palbociclib in a first line or a second line as compared to things. There were a lot of reasons for it, but our topic is second line. So Paloma 3, if you look into the primary endocrine and a secondary endocrine subset, in fact, in a primary endocrine subset, see the right side, it was only 20.2 months as against placebo with fulvestrant, which was 26.2. So in fact, there is absolutely no probably used in giving a primary endocrine. In secondary, it was improved, but it was an exploratory endpoint. So palbociclib, probably the data is against giving it in the primary endocrine resistance. Next slide. Now comes the third player, that is a ribociclib. So this was the updated analysis which was published in ESCO 2021 by Slamon et al. Now, when you look into the endocrine resistance again, there was a benefit, but please remember the first thing was this was an exploratory endpoint, not a predetermined endpoint. The second important thing is when you look into hazard ratio. I'll again tell you not to compare or cross trial, but then when you have to take out some point, this is the only way you can compare. The hazard ratio in primary endocrine resistance is 0.81 against 0.68 in the Monarch 2 study. So probably there are two drugs which are available, but when you look into the quantum of benefit and the peculiar mechanism of action of abemaciclib, which is pan-CDK kinase inhibitory, probably I can call it, that is a more potent drug, and we have already seen in a cross trial, although we should be careful again to do it. So for me, the more potent drug in a primary endocrine in terms of 3 is abemaciclib. Next slide. So this was a finding in January 2021. There was FDG-avid mediastinal upper paratracheal, what I have mentioned. And when we did the first interim analysis in July 2021, there was no disease at all. So all the lymph nodes had gone. A single subcarinal node was there, but it did not have any FDG activity. And more importantly, there was no lesions. The patient tolerated. These were one of the few earlier patients, and the patient did quite well. No diarrhea, no neutropenia, no liver cell abnormality, and no creatinine, which are the 4 important things. The patient continued to do well. Next slide. Now you can see the scan again of that patient. There is a single subcarinal in the second part, which is seen probably, but it has lost its activity, and all the other nodes had disappeared. Next slide. You can see the single subcarinal node probably with no FDG uptake. Next slide. So the PET scan revealed there is no abnormal soft tissue or metabolism. There is a low-grade metabolism in subcarinal node, and there is no evidence of disease elsewhere. And as compared, there was a disappearance of this, all the mediastinal lymph nodes. Next slide. So one of those cases where the patient relapsed early, but with the probably I can say a right partner and at the right time, the patient is doing well. Patient is asymptomatic and is on the drug at present. I thank you all for a patient hearing of my case.
Thank
Next
you
slide.
very much, sir. For what I can say that magical case with a primary hormone resistance with a CR. So this is a dream of all medical oncologists probably. And coming to the next topic of today, question and answer with experts, trailing the treatment in hormone receptor positive metastatic breast cancer. Based on the prognostic factor, I will like to invite Dr. Shirish Alulkar sir, who is a consultant medical oncologist at Apollo Cancer Center, Ahmedabad. Welcome to you, sir.
Thank you, Dr. Belajani, and Dr. Vaswani, good evening to you.
Good evening, sir. Good evening.
Thank you, Lily, for making this possible, and thanks the organizers also for inviting me and giving this chance. I think we have a very informal talk, nothing like a panel discussion, something like a cross talk between me and Dr. Vaswani sir and even others who are online. So we'll keep it as informal as possible. So as Dr. Vaswani highlighted that now we are spoiled for choices between these three CDK, CD4 drugs. So one has to really taper down, one has to really identify which is the patient, which Dr. Vaswani said, based on various profiles, profile depending on the patient profile or the biology of the tumor, and based on which we select the drugs. And most of these drugs have, all of these I would say have got an approval based on the PFS, except 2 drugs, which is the abemaciclib and ribociclib, which have got the approval based on the OS. Palbociclib, unfortunately, as Dr. Vaswani said, although it was the first player, did not really make its mark as far as the OS was concerned. So some small questions here that in view of our experience with all the, could you shed, this is the first question, right? Are you sharing the slide from your side?
Yes, sir.
Okay.
You want to share your slides, sir?
No, you carry on. You can do that.
Okay. Just say next time you want to change the slide, sir.
Okay. So, which characteristics you think which you will highlight or which will help you to select, apart from the cost, of course, in making the choice for, say, ribo versus palbo versus abemaciclib?
So, sir, when I have to answer it, actually, I have told that there was some characteristic that I already discussed. The first thing I think so we should determine about the drug is what is the presentation of the disease. So, whether it is a endocrine naive patient or whether it is a endocrine resistance. When I talk about again about endocrine resistance, whether it is a primary endocrine resistance or a secondary endocrine resistance. Now, with the data available and with the discussion that I made, in a primary endocrine resistance, I think so the best data in a pre-specified, or we can say, is of abemaciclib. The other data probably may be good in case of ribo, but not as impressive as abemaciclib.
Mhm.
So for me, the first thing is the presentation. The second thing is what we said is how bad the disease is. Now, the indirect surrogate markers that we discussed was a liver met or a visceral met or a high-grade disease or a PR negative or a premenopausal. So probably when you have multiple high-risk factors, probably you should have a more potent drug here. Again, there will be either you should choose the ribo or you should choose the abema. Then again, it depends upon how confident are you giving a drug and the characteristic of the patient. So a compromised marrow, a cardiac comorbidity, you should not think of giving a ribo. Similarly, if you have some irritable or inflammatory bowel, maybe that is the only thing where I may not think of giving a abema. So the fight is between abema, ribo.
Right.
Probably for me, because of its unique mechanism of action, maybe a continuous dose, a added CNS advantage, and probably a side effect profile which is different, and a pan CDK4/6 activity. Probably I may incline myself of using abema when most of these poor factors are present. Of course, I will use it in endocrine naive also, because again, if you do a cross trial comparison, the palbo 53 months, ribo 58 to 64 months, and when you took into abema, it was 67.3 months. Maybe these are all things with accept 0.75 hazard ratio. So naive resistance, probably now the things are getting clearer with OS data available, which is probably drug you can use. Rather than interchanging, we need to understand that all these three drugs are different now with over a long period of time, what we have realized now.
Right. So would the menopausal status have any influence on your choice, or premenopausal will be more inclined towards one molecule and the, say, postmenopausal towards one?
Sir, the thing is, now if you see the data for premenopausal is for all the three drugs. I'll start with the major drug ribo, the Mona Lisa 7 data.
Mona Lisa 7.
Yeah, which had a OS of 58 months, quite impressive. But when you look into the data of Monarch 2 also, around 16% of the patient was premenopausal. And when you look into the hazard ratio or the response or the overall, this was better than what we had in the entire population. If you see the subset analysis in this premenopausal.
Right.
Now, even Paloma 3 has a subset of premenopausal patients. So, sir, the thing is, you have two drugs. Now, if you see the entire data, if you say the strongest data, or not, I can say strongest, but the major data is of ribociclib. But again, the thing is, when you give ribociclib, one more important thing which remember and which people might discount is you cannot give tamoxifen with ribociclib.
Right.
So whenever you are thinking of ribo also, you should have to give a GnRH analog and put her on a letrozole, because we know that tamoxifen, there will be QTC prolongation chances. So that is an added disadvantage, although there is a data, but you need to modify your plan. Now, I am comfortable. I have quite a few patients whom we have used abemaciclib in a premenopausal, and we have a data to support it. The only thing is it was a subset of a data from a Monarch study, and it was a complete study. But sir, I think so. It is probably aggressiveness of the patient which should tell us which is the best agent. Maybe some other differences might be there.
Okay. So next slide, please. So again, just same thing. What will be the treatment of choice in this subset of patients with multiple metastasis, especially say visceral metastasis and a symptomatic disease, not a crisis? So next question will come. once you choose this drug options?
Sir, now the data is there which suggests that even in these subset of patients with a visceral mets or a symptomatic disease, now the dictum is you need a drug which acts faster when you have these diseases because these progress very fast. So that is the main thing. So you need a drug or an agent which works very fast. Now we have seen that at the first interim analysis in those patients with a CDK4/6, there is the appreciable benefit starts. So for me, the advantage is chemo you give for a short period of time. Subsequently, the cancer progresses. CDK4/6 inhibitor being an oral tablet along with endocrine, you can give as long as the patient can respond to it. Although there should not be any cross trial again also. But for me, because CDK4/6 inhibitor works faster along with the endocrine agent, so the main, and they work for a longer period of time also. So my choice, I don't think so there should be any confusion here. It should be an endocrine therapy with a CDK4/6 inhibitor, irrespective of whether you have a visceral mets or not, or whether a patient is symptomatic or not.
And any specific, but in my practice, if I have a liver metastasis and there is no particular contraindication, I would prefer Abima over say Ribo or Palbociclib because of the data.
Agree, sir. The thing to remember is the liver bad disease. So you need the best drug or a more potent drug because you want the patient to respond well. Although there is data for Ribo also, but at the end of the day, sir, it is what you are comfortable with also. And if you look into the hazard ratio also, in those with the liver met in a PFS, it was 0.5. The hazard ratio, and it is 0.6 to 62 in Ribo. Again, sir, you should be careful in doing a cross trial. But at the end of the day, probably when you need to say, this is one of the better drugs that you have, and you should take use of the best drug in the first line or in the earlier part, when the patient is fit enough to tolerate all that.
So I know my next question may sound rather naive, but rather than wait for a patient developing visceral crisis and then go for chemotherapy, if there is a visceral metastasis and symptomatic, what is shown in the question, why not give chemotherapy first? It's going to act faster.
Yeah.
Sir, so that's always a question. Why wait for a crisis and then you take an action?
Sir, by giving this CDK4/6 inhibitor with endocrine, the patient responds. So you are averting a crisis. The patient will never get a crisis at all.
But with chemotherapy also you may avoid.
Yeah. No, I agree. Sir, what you said is when you give chemo, you can avoid. Even with CDK4/6 and endocrine, you can avoid it. Okay. Sir, the response rate, if you see, are 50% in the first line and in the second line. The disease control rate is 75 to 90%. Even chemo doesn't have such a good rates also. So the thing is, when you compare the two, you compare is based on response rate, PFS, and OS. Now, the only advantage where chemo, you may think of chemo also was when it is rapidity of response. But we have seen that by adding a CDK4/6, that rapidity of response comes. So there is no advantage of giving a chemo because you have a drug which is having a equivalent or a better response rate, a better PFS without doubt. And all now with OS data available, there is a better overall survival.
And relatively less toxic than chemo.
And relatively less toxic, and oral tablets are taken at home.
Yeah, that's it. Okay, next question, please. Okay, just go back the slide. Just go back. But in your case, you mentioned that of course you started upfront CDK, CD4. But in real practice, sometimes what happens that patient is with someone else, say I wouldn't say a surgeon or someone, and patient has received chemotherapy for a metastatic disease, HR positive, HR negative. So this is a subset of patient who has received one line of chemo and progressed on that, now comes to you. So would your choice of drug based on whatever data is there change, say, versus say Palbo, Ribo, or Abimaciclib based on the data?
Sir, excellent question to start with. Very good question. That is something never discussed. Sir, when you talk about Palbo, when you talk about Palbo, it was what we say Paloma studies, Paloma 3. Right. They had used a chemotherapy that was allowed. But
about
that
34%.
Was a failed yeah. So that was a failed study. So our discussion should rest on Ribo and Abimaciclib. Now, when you talk about Monarch, everybody forgets that we have a data of Monarch 1 also. These were the patients who were heavily pre-treated patients and had the best response among when you compare with chemo also. So it was a second or a third line. These were all had received chemo and they had received a hormonal also. So in a patient who is treated with chemotherapy, we have a good data to suggest that abemaciclib as a single agent also works.
Right.
Now, in this case, we have not been given any hormonal therapy, and we know these are symbiotic basically. So for me, if I have a patient who has already received chemo, the drug with the best data is a abemaciclib based on Monarch 1, probably yes. And since we have not given any hormonal, I think the best way to give it off, even in a patient those who have used chemotherapy, is combining it with endocrine. We have other data of next Monarch also, but then that is beyond the preview of this. So for me, a patient who has received chemotherapy, the best data is for abema. If I don't remember Ribo having this data here in any of the studies.
They don't have pre-chemotherapy.
Yeah.
So the reason why you said palbociclib failed because you don't have the OS data, right?
Sir, in both the settings, sir, the problem is even in second line where abema and Ribo had a OS data, it failed. Now in the first line, Ribo has a data now, 58 to 64 months. There is a data which is there. Or the data for, if I say abemaciclib, unfortunately, sir, it is 67 months, but it was not statistically significant. But abema, the events were around 250. And the final outcome will be decided after we have a 325 patient data. But that hazard ratio of 0.75, the p-value is 0.03. But again, I'm not sure what was the predetermined endpoint. Even that doesn't cross unity, the higher endpoint. But for now, they said that it has to still be, we have to have a long run or a further thing, so that final OS data has not come. But in terms of quantum, if you see the hazard ratio 0.75 in primary endocrine, 0.75 in first line as well as second line. Probably if you see the Paloma data, it is 0.92 because that quantum is not so big.
Yeah.
So that is also a thing.
Yeah. So personally, I feel they have selected a more higher or resistant sort of population. And just because it is not proved by OS, just the DFS. But if we assume that DFS is a surrogate for OS, there's no reason why Palbo should not also work. Maybe with time, probably it will also come out with the OS data. Let's see. Dr. Sahu has asked one question. I think it relates to the Paloma 3. What he asks is it
one? I think it is Monarch 1, sir. Just one line or multiple lines of
No. My question was more into, I understand what Bharat speaking. I wanted to know what Bharat means is that the other two CDK4/6 don't have a data with single activity where the abema has in multiply failed. The single agent activity was also something which we can consider. Point number one. That's if I got him right.
Yes.
My question is, I always feel as a clinician, our thing should be that when we choose a single agent abema or any CDK4/6 single agent, if we feel all of them are same, we should always compare it. That is chemotherapy, any line, second or fourth or third line. If two lines have failed, the next chemotherapy is going to be better, or CDK4/6 single agent is better. The comparison should not be CDK versus CDK. At that line, I feel that it should be abema or any CDK versus the possible chemotherapy regimen that is left. So that is what I think is how I will choose my thing. Bharat can comment on that.
Point very well made, sir. You always make pertinent points, sir. Sir, the thing is, when you discuss about Monarch 1 data, at the same line, the responses, it was 19 to 22% what we say. The chemotherapy responses are less and their PFS is also lesser, sir. So even in those lines where you have multiply used chemo or not, when you compare with chemo at that line, single agent CDK4/6 inhibitor did better than chemotherapy at that line also.
Is that okay with you, Dr. Sahu?
Yeah, it's always okay with me, but okay. I think that's how it should be.
But we don't have the data. We don't have the data. Yeah, that's true. But in clinical practice, what would you do? Let me ask you, Dr. Sahu.
Regarding which one?
Your question, one line or second line, what do you do?
See, if it is a one line or two lines, I have my agent. Let's say I failed anthracyclines. I have still left with taxanes, and I've left with eribulin as agent. I've left with capecitabine as agent. Okay. I will not give CDK4/6 single agent. I'm very categorical about it. Even if you look at the frontline things, there is data. Although we can criticize the data, I'm forgetting the trial name. Bharat is more specific. He can tell me the trial name. There is more than one trial. Again, the same series, I think the East Asian region se trial hai, and we have looked into that the hormone positive, even the frontline chemotherapy also with capecitabine looks in the failed taxanes and anthracyclines.
Sir, Pearl study, young Pearl and Pearl study. That is
I know,
Pearl and
Bharat
young
will tell
Pearl.
the name. I know. So in that, with the criticism, the point I get is chemotherapy is just you taking away chemotherapy from this subset of patient is not a good thing.
Okay.
Where will I consider CDK4/6 or any hormonal agent when chemotherapy has shown resistance very quickly? The same thing goes for hormone therapy. If I have a patient failed with the hormone therapy very quickly, I will probably rely on chemotherapy more in those patients. And all of us have had those patients who are ER positive, HER2 negative. And when we give hormone in 2-3 months, they fail. And when the chemotherapy comes in, they do very well. There could be some resistance mechanism to hormones. So that is how I think we have to proceed.
Sir, overall, in a hormone positive strong, chemo is basically, they don't work at all also. The chemo works mostly in negative settings. That has been even in this ASCO also, even in high genomic signature in elderly, it did not work. For my point is, when you have been multiply treated chemo, you have already exhausted your taxane.
Yeah. So the key word is
either eribulin or something. So I think so. If you do a cross trial comparison, these are positive subset now. So for me, maybe I might be, but sir, I think I will prefer a abemaciclib single agent.
The key point, Bharat, was multiply failed chemo resistant. Then abema comes in. You won't use it instead of a taxane. That's my point.
Sir, I'll use earlier abema and I'll keep it taxane when maybe in the third line, maybe when I exhaust my first and second line. Sir, that is what, and even because weekly taxane, hopefully that at that time also patient will tolerate, sir. But for me, because this is the longer data, if you have to compare PFS of 14 months, you can never get a PFS of 14 months with a chemotherapy, sir. That is the only thing. My crux is when you give a drug who has a better PFS than a chemo, probably we should give it in the first, because the main aim is to get that OS now. So at the end of the day.
So Dr. Rao.
Some other day, I will have a debate on this with you.
So Dr. Sahu is a pro chemotherapy and Dr. Vasa.
No, I'm not pro chemo.
Okay.
What I meant, the take home should not go wrong.
Right.
Single agent CDK4/6 pushing into not giving effective chemotherapy earlier is something which I'm very skeptical.
Sir, I'll just put one point, sir. Sir, now we have a data which says that you can give CDK4/6 inhibitor after CDK in this ASCO, but it was not, it was for Ribo.
Okay.
So Palbo failure, Ribo given in a later still worked. Maybe just discussion, sir. We'll discuss some other day.
So, but I really don't know what happens after failure of CDK4. I mean, pick 3CA, how many can really afford? Let's forget that. But what happens if you give chemo after? That's a very hypothetical question. I don't know how is your experience? Do they tolerate? I mean, do they respond to chemotherapy after CDK4? I don't know. I am not very much.
I think the answer is there. We have reports on that. The chemotherapy response does not change much. It is either way.
Okay.
I don't think there is much into that. But the only thing is that the patients who fail later, the mutational pattern is much different than patient who failed within first 6 months. That is important.
And now we are having more effective search, sir. Maybe some more better than fulvestrant. So probably in the future we'll have a lot of new gut drugs, sir. That is the wonder of this, sir. The way the breast cancer treatment is evolving is too fast, sir. So two certs have already been approved. So probably we'll have in future, and we are. But yes, I agree that we should not discuss beyond that. Pick 3 somehow, my experience also have been a bit scary.
Okay, so I think we can go to the next question in the view of the time. How much time do you have? The Horizon people, you can warn me.
1 minute.
1 minute. Okay, last.
2 minutes.
I think we'll just next slide. We'll rush through now. So of course, continuous dosing. It's anything particular I have to say apart from the pharmacological benefits of this one and the logistics. Any other benefit you feel of abemaciclib continuous doses? I personally feel that it's very easy for the patient, also for us, because then we know that there's nothing like an off period. So there's nothing like forgetting or that sort of thing. What do you think, Dr. Basra? Is that an advantage? I think it is.
That was the main basis of starting abema, a drug with a continuous and a CNS penetration. So that was the basis on which the abemaciclib was devised. And I'll bend off that.
I think that's a more or less settled question. Next one.
Yes.
I think toxicities you have covered will be not much of this. Any particular like to put anything apart from this? What is known here?
The only thing is we have some amount of DVTs also. That is something that we have to be careful. Otherwise,
I was going to ask you, you don't use prophylaxis, right?
Yeah. So probably yes, sir. If there, it has to be treated like what we have treated for other drugs also. So a low molecular weight heparin, and probably in the newer trials, what is there? They are omitting. This is the exclusion criteria. So a history of DVT, they are not taking it in the earlier. It was there, and you have to manage it like a standard DVT protocol. Other than that, diarrhea is manageable. Some degree of neutropenia, some LFT abnormality, and some GI toxicity. And one more is increased serum creatinine, because there is an inhibition of tubular secretion. That is also not, we have to do a cystatin level rather than measuring our creatinine to monitor this. And it is reversible, sir. That should not be.
And next question, this was the last
one. Can we end, sir?
Yeah, this was the last one, I think. Yeah. Thank you. Thank you very much, Dr. Vaswani, sir. Good discussion we had. Thank you, Lily, for this panel discussion. Thank you.
Thank you. Thank you all for the opportunity. Thank you.
Thank you, both of you. Thank you, sponsors. And it's always great to listen to Bharat. We sometimes differ on things, but it is always good to differ on science. And that's what
we learn from you, sir. You are one of a good teachers that we have.
Thank you. Thank you for those. And we time to move on. And first of all, now I would formally like to thank all the faculties who have taken up the invite. And this will be a good 2 to 3 hours of scientific feast on breast cancer on behalf of BCOS and Dr. Naresh. Actually, I would like to invite all of you formally into this next 2 to 3 hours of scientific feast on breast cancer. And the first one to go for the next 15 minutes will be Dr. Bharat Rangarajan, who is a dear friend and a consultant medical oncologist practicing at Coimbatore at Kovai Medical Center and Hospital. And I don't think he needs any further introduction. And the next 15 minutes, he will be speaking on personalized adjuvant endocrine therapy in early breast cancer. And I feel as a medical oncologist, this field is also changing. Myself, I have changed my practice. I've been giving longer durations. I've been adding LHRH agonists to a lot of my premenopausal. Let's hear Bharat and find which patient needs a prolonged therapy, who can be excluded, and which patients we need to modify our hormone treatment.
Am I audible?
You are.
Okay, so the control of the slides are, I think, with the So thank you, Sahu sir, and the entire BCOS team, because it's wonderful to have another meeting, and I'm really enjoying I was really enjoying the previous CDK4/6 session and the debate on it. But this is slightly, I think, older, and will again end with CD4/6. Historically, if we were, going to, if we go back 60 years, it was very easy. Maya Cole started using tamoxifen as adjuvant therapy in all women with breast cancer, regardless of menopausal status. Tamoxifen itself, interestingly, was developed as an oral contraceptive agent, and it failed as an oral contraceptive agent and found use in breast cancer, and that was it. Slowly, we had development of anastrozole, letrozole, and few other drugs which are no longer in use. And postmenopausal women were treated with AIs. Next slide.
I think your slides are not up. You are visible.
No.
Yeah, now the slides are on. But anyway, you also look lovely on it.
No, I don't.
These are my slides.
No, those are not my slides.
Sir, we don't have your slides, sir.
I will share them once.
So please allow him to share, please.
Yes, sir.
1 second. I'm sorry about the glitch.
That was Amol's slide, no?
Yes.
I'm sorry.
The thing with just you lost the starting.
Yes. So are the slides visible now?
Yes.
So we started with tamoxifen, and then we moved on to premenopausal patients getting treated with tamoxifen, postmenopausal patients getting treated with AI. Now, when we look at endocrine treatment for early stage breast cancer, the options that have come in the decades, ovarian suppression with LHRH analogs in high-risk premenopausal women. the duration of therapy, whether it is 5 years, 7 years, or 10 years, how long we treat these women, and of course, the most recent advances, whether we add a second endocrine agent, that is a CDK4/6 inhibitors. But when we look at tamoxifen and AI in the in the postmenopausal women, this is from the EBCTCG meta-analysis. There is an absolute gain of around 3.6%, and in breast, this actually results in a significant difference with a relative risk reduction of 0.8. The controls are, to one side of unity. There is definitely an improvement when we use AIs in the postmenopausal women. So from AIs, I will just start with the premenopausal women. What is the status of ovarian function suppression? And in this arena, we have two clinical questions. Do we use OFS plus tamoxifen or AI? And does this tamoxifen or AI over tamoxifen alone? That is the first question. The second question is AI a better partner with OFS than tamoxifen? So this we know the initial trial is, of course, from the SOFT, and the text, not the initial trial, the largest trial that tried that evaluated this was the SOFT and the text. The SOFT, only one arm of the SOFT had 3 arms, that is tamoxifen plus OFS, and AI plus OFS. The SOFT alone was published, just the 2 arms of SOFT were published. And in the 2 arms, actually, there was not much of a difference between tamoxifen alone or tamoxifen plus OFS. So what happened in the SOFT was that whether you gave tamoxifen or whether you gave tamoxifen plus OFS, the overall survival advantage was not huge. Subsequently, the SOFT and the text, there were 2 common arms for both SOFT and text, that is the OFS plus tamoxifen or exemestane plus tamoxifen. So the data from SOFT and text were pooled. The analysis was published in NDG, and we look at the pooled analysis. There is a small but definite significant improvement when we use OFS along with tamoxifen or OFS along with exemestane, and this benefit is seen in premenopausal women over and above what we see with tamoxifen. So we cannot say that this whatever this difference is huge, but this difference is significant. So there is a 4% absolute improvement in the 8-year DFS for exemestane and ovarian function suppression after 9 years of median follow-up. So this is a long-term follow-up which is showing a significant improvement and a 2.1% absolute improvement in freedom from distant recurrence, that is freedom from metastasis. And these numbers, while the delta appears small, in breast cancer, these numbers are quite important, because of breast cancer numbers itself, it is the leading malignancy in the world, and definitely now in India also. However, one thing that we have to understand, that exemestane plus OFS versus tamoxifen plus OFS, at 9 years, there's not much of a difference in the overall survival. Of course, we always know that there is a post-progression treatment and that will have an impact. And now, of course, there are many more endocrine therapies that have come into the picture. So these women would have all gone on to second-line agents when they got recurrence. So there was not much of an overall survival advantage. There is, however, a meta-analysis which looked at 4 trials. That is the SOFT, the text, the ABSCG trial, and the HOBO trial. And when all these trials, the meta-analysis looked at tamoxifen plus OS versus aromatase inhibitors with the OFS. OFS plus AI in premenopausal women actually offers around a 3% benefit in DFS at 5 and 10 years. This is over and above what we get from OFS and tamoxifen, and this is from 4 large trials with fairly homogeneous sort of women. And all-cause mortality. However, there is definitely a DFS benefit. OFS generally, so we know the question is always, I'm not going into a lot of discussion on that, but OFS, whom to give? OFS generally benefits women who have high risk breast cancer. And who are these high risk women? Women who are less than 35 years old, Women who need chemotherapy, this could be based on clinical risk, that is more than 5 centimeters, node positive women, or women who have high recurrence scores based on any of the gene expression profiles that we use, Oncotype DX or any of the other available ones. And these women who need chemotherapy definitely benefit from adding ovarian function suppression. The point to remember is when we look at it the other way around, what happened in these trials to the women who did not need chemotherapy or did not take chemotherapy? These women, actually, the magnitude of benefit was very, very small. But please remember that these are women who have either had tumors that are less than 2 centimeters, along with no nodes positive, and mostly low grade tumors. So the best of the lot did not get chemotherapy, and these women did not really benefit much from adding OFS to tamoxifen or OFS. Actually, in the soft and the text, more than 95% of women in the tamoxifen plus OFS and AI plus OFS were alive. All three cohorts, more than 95% of women were alive at 9 years. So these women do well irrespective of whether you add ovarian function suppression or not. Now, coming to the second question, how much duration do we give adjuvant endocrine therapy? Is it 5 years, 10 years, or somewhere in the middle, around 7 years? So the ATLAS and ATOM trials, ATOM is the NHS trial. ATOM trial never had the full publication, and the ATLAS, and or whether to give tamoxifen followed by an AI in perimenopausal and postmenopausal women, or AI continuing an AI beyond 5 years. So what are the data that we have? This ATLAS is a randomized trial. They randomized after 5 years of tamoxifen into another 5 years versus observation alone. And when it was at the final analysis, final publication, not much of a difference in the first 5 years in DFS or in the OS. The curves actually begin to separate only by the 8th or the 9th year, and a maximum separation is seen around at the 15th year. So after follow-up, what one finds is that there is a definite delta of around 4%. There is a 4% absolute improvement when you have continued tamoxifen beyond 5 years. But this effect is seen only on long-term follow-up, only in women who have been followed up after 10 years. And the same, the overall survival also, there is almost a delta of 3%. And this also is actually seen after the 10th year of follow-up. So it is a long-term OFS and the long-term DFS that is actually improved when you're giving a longer duration of tamoxifen. So, and this benefit, if you look at the forest plot, is nearly seen in almost all subsets. The MA17 to either letrozole or to placebo. So it is a switch trial. Again, this trial also very, very similar, shows a good proportion of patients who are disease-free. That is, the disease-free survival is significant. Go on an AI at progression. So the overall survival was not very significant. The NSABP is another large trial of 3,000 women. Again, this trial had the same design where tamoxifen followed by exemestane versus placebo, and the randomization was after 5 years of tamoxifen. A small but significant difference in the hazard ratio of 0.44, 2% delta, significant 2% absolute improvement in the event-free survival. But again, NSABP did not show survival. We must remember very few of these women are actually relapsing. So and they're getting post-progression treatment. So it's very difficult in this subset at least to get the overall survival advantage that they got in say ATLAS trial. Now, if you look at 10 years, the 5-year disease-free survival is around 95% with letrozole and 91% with placebo, a 4% delta. But there is quite a difference in the nearly 3 times the women develop a contralateral breast primary. So the contralateral breast primaries are definitely higher when the patients were on placebo compared to a 10-year letrozole. Now, this trial from Nat et al. Was published in MEJM last year, and this is addressing a different question of at 5 years they randomized to 2 years more of letrozole versus 5 years of letrozole. So we are not even sure whether 10 years of letrozole is a standard, but anyhow, this is 7 years versus 10 years of letrozole. At 10 years of letrozole, there's not much of difference. You gave the drug for, sorry, this is anastrozole, I'm very sorry. So whether you gave an AI anastrozole for 7 years or for 10 years, your rate of proportion that was disease-free, that is a disease-free survival and the overall survival remained the same. What was different, however, was there was a significant higher skeletal-related events in the 10-year arm. So this is a summary of all the trials. Most of the trials do show some improvement, an absolute difference of around 2 to 4% when you're using an extended AI or an extended tamoxifen. But the tamoxifen, the Atlas did show some survival advantage. However, as of today, we don't use tamoxifen for 10 years because we would rather go the OFS plus tamoxifen or OFS plus AI route for patients who are premenopausal with endocrine positive sensitive breast cancer. So the 2 to 4 percentage absolute DFS advantage, and there is definitely a reduced contralateral breast malignancy rate. Is with a higher uterine second malignancy. It is around 2% when it is in when you use it for 5 years, and around 4% when you use it for 10 years. But this effect is mainly pronounced in postmenopausal women. And premenopausal women, this is not a great risk. So extended AI, especially 10 years, is associated with higher skeletal related events and vascular events. So to conclude, extended adjuvant endocrine therapy in highly selected high-risk women who are not on OFS may be offered 10 years of tamoxifen, but that may not be a sort of choice any longer. AI for 7 years may be appropriate for postmenopausal women, but this should be definitely personalized against the risk of higher fractures. Switch maintenance trials, many trials have happened, especially for the perimenopausal women. It's a good idea. If you're not planning for OFS, we can definitely use tamoxifen, and once the patient becomes menopausal, switch to an AI with a total duration of 7 to 10 years. So the toxicities are opposite. So tamoxifen protects the heart, has got a good effect on the cholesterol, whereas AI does the opposite, and shorter duration of tamoxifen reduces risk of uterine malignancy. Shorter duration of AI will reduce the risk of skeletal related events. So that may be a good choice for women, especially who are premenopausal women who have not used OFS. So the last part is addition of adjuvant CDK4/6 inhibitors. There are 3 trials. One large trial is still pending final publication, that is the Natalie, which is evaluating ribociclib, but we have data from Monarch E, the Pallas and the Penelope. Now we know that the Pallas and the Penelope B trials were negative trials, but these trials are a bit different. For example, the Penelope B allowed randomization even 6 months into endocrine therapy. So a woman who had been 6 months in endocrine therapy could still go on Penelope B. Whereas 12 weeks of starting the endocrine therapy. So right from randomization, there are a little bit of differences in the, which might be a cause for the differences that we see. But anyhow, the Monarch had 2 cohorts. The first cohort was more than 4 positive nodes in the axilla, or 1 to 3 nodes positive plus either high grade tumor or tumor of 5 centimeters. The cohort 2 had more than the important thing in cohort 2 was a Ki67 of more than 20%. They were randomized to 150 milligrams of abemaciclib versus standard endocrine therapy. Duration could be 5 to 10 years in both the arms. The standard endocrine therapy, that was the physician choice. The key secondary endpoint which the trialists had in mind was a IDFS, that is invasive disease-free survival, based on the Ki67. But the primary endpoint was DFS. these are the baseline characteristics, fairly well balanced in both the arms. The key 67, we must look. This is the key 67. Less than 20 is around 34%, and more than 20% is around 45%. So this is the sort of, because key 67 is now becoming the sort of deciding factor on whether we are going to use abemaciclib or not. The primary endpoint, which is
Bharat, a minute more. Bharat, a minute.
Yes. The primary endpoint, which is the invasive disease-free survival in all patients, was definitely met in this trial, and there was 92% 2-year IDFS in the abemaciclib arm versus 89%, a delta of around 3%, which was with a hazard of 0.7, which was significant. And this was seen in patients who had prior chemotherapy, either in the adjuvant or neoadjuvant. This was favoring the women who were taking the adjuvant chemotherapy or neoadjuvant. This was irrespective of that, and also both postmenopausal and premenopausal women. And the rate of distant recurrence-free survival, which is a very important parameter in the clinic, more than IDFS, was also, the delta was around 3% at 93.8, 90.8. 2-year. So the data is still a bit early, but this is significant with a hazard ratio of 0.68. The key secondary endpoint stratified based on the key 67. There is a 3% absolute improvement in 2-year IDFS rates for patients for the entire cohort. The absolute improvement in patients who had more than key 67 of 20% was 5.4%. Whereas for women with key of less than 20 is only 2.8. We are still waiting for the overall survival results from this trial, and of course long-term follow-up on whether these curves remain separate, because a 2-year IDFS, and remember the drug itself is used for 2 years, so the effect washout and the effects may be seen only a little later. To summarize, OFS definitely we must personalize in women who are less than 35, women who have high clinical risk like high-grade tumors, T3 tumors, node-positive tumors, and if you got high recurrence rate of risk of recurrence or score on oncotype DX or any other genomic score. Extended AI to 7 years definitely may offer a DFS and an IDFS and a contralateral breast cancer reduction advantage, with a small increase in skeletal related events, which can be managed with bisphosphonates or denosumab. Extended tamoxifen is maybe a highly personalized choice only for women whom we are not using OFS, and may not be for all, at least at this time. A switch maintenance, especially women who become postmenopausal, is a better option, or OFS. Addition of CDK4/6 is actually improving the 2-year DFS in all subgroups, but the best results are definitely seen in the group that has got a key 67 more than 20%. Other agents are, at least the trials are not effective. So to risk stratify based on clinical genomic key 67 age, pre and perimenopausal, and use tamoxifen OFS AI switch therapies. OFS plus tamoxifen with this meta-analysis that just came in may not be, we may go for OFS plus exenestane, and extended tamoxifen for some patients, and maybe abemaciclib based on key 67. Similarly, in postmenopausal, key 67 is important, and AI of 5 to 7 years, and abemaciclib. So these are the ways we can think of personalizing adjuvant endocrine therapy. Thank you.
Thank you, Bharat. It was a great to listen to you, and I think all of us need to relook at how we do practice adjuvant endocrine therapy in CF breast. It's a not so new subject, but still most of our practice has not changed, and that's why I felt that this was a very important talk. So now coming on to the debate, the questions can come on in the chat, and Bharat will be more than happy to answer those. We have interesting debate, and we have something like in the front line, triple positive metastatic breast cancer. Is trastuzumab and hormone therapy or trastuzumab with the chemotherapy the best option? And we have Dr. Amol Akhade, who's the senior medical oncologist from Bombay Hospital, Mumbai, to be speaking in favor of trastuzumab and hormone therapy. He has 10 minutes, and again after him will go Kripa Shankar, a dear friend from Coimbatore, and he will be speaking for trastuzumab or HER2 targeted and chemotherapy. First option is the preferred way to go ahead. Dr. Moore.
Yeah, am I audible?
Yeah, you are.
Yeah. So can we have the slides? First of all, let me thank the organizers for inviting me for a debate. And today I will be talking about triple positive breast cancer, trastuzumab plus endocrine therapy. Next. So who should partner trastuzumab? Now, yes, the answer, if you think, is as simple as this, or maybe as complicated as this. Trastuzumab plus chemotherapy has a long-term data, probably is more effective, but as you all know, that it is probably more toxic. Endocrine plus and trastuzumab, we don't know because the data is much less, probably toxicity is less. So it is very difficult to answer this, but we'll try to look at whatever data that is there as far as trastuzumab plus endocrine therapy. Next. Now, rationale for endocrine partner. Now, see, chemotherapy-free regimen is the latest fashion in ER positive and HER2 negative. And endocrine plus CDK inhibitors is the first line in ER positive, HER2 negative. That means in ER positive, HER2 negative, we don't want chemotherapy to be given in the metastatic breast cancer upfront. So why not in ER positive, HER2 positive, we can have a chemo-free regimen with an endocrine plus trastuzumab. So there is a crosstalk between ER and HER2 pathway, and HER2 overexpression may lead to endocrine resistance, and hence upfront targeting both pathways can be effective. Next. But surprisingly, if you see, there is only one phase 3 randomized control trial. This is very surprising. In fact, I was telling other day to one of my colleagues that if someone wants to do a phase 3 randomized control trial with a sure shot publication, this is the way, this is the exact field in which the trial should be done, because there is actually in the entire world, there is only one phase 3 randomized control trial. It is a Chinese trial. It was done by Chinese Breast Oncology Group. It is published in AACR journal in February 2022. It is a phase 3 randomized trial, 392 patients. And if you look at the patient population, and they have both de novo metastatic as well as those who are relapsed after adjuvant or neoadjuvant therapy. And the population is similar to Cleopatra trial. And the median PFS was 19.2 months in previous slide, please. Yeah. Median PFS was 19.2 months in endocrine arm versus 14.8 months in the chemotherapy arm. The trial was powered to show non-inferiority of the trastuzumab plus endocrine arm, and they had generated a p-value showing that it is a non-inferior to the other arm, that is the trastuzumab plus chemotherapy. So look at the numbers: 19.2 PFS for an endocrine plus trastuzumab arm, and there is no, of course, no difference in the OS. The chemo arm was more toxic than endocrine arm. There were 5.1% grade 4 toxicity as against 0 grade 4 toxicity in endocrine arm. Next. So trastuzumab plus chemo is toxic. If you see the data from the Cleopatra control arm, in which the control arm was trastuzumab plus docetaxel, 60% patients had diarrhea, 50% had neutropenia, 28% have what we called as vomiting, and almost 8% have febrile neutropenia. So trastuzumab plus chemo is a toxic regimen, and mind you, this is the data from a clinical trial in a control setting. And in that trial, if you get so much of a toxicity, in the real world, the toxicity of trastuzumab plus chemo is going to be even more. Next. Next slide. So why there is a less enthusiasm for this approach? If you see, there is only one randomized control trial, and of course we can blame it on Cleopatra. It has raised the bar for PFS in metastatic breast cancer. Unfortunately, that trial did not allow endocrine therapy with anti-HER2 drugs. We don't know why. The trial was designed to get pertuzumab approval, which had failed prior to as a single agent. The trial had almost 80% patients with visceral disease. Now, it is important to note that the control of Cleopatra, trastuzumab plus docetaxel, had a PFS of 12.4 months. Now, if you remember the previous slide, our Chinese trial had a much larger PFS, a longer PFS than the control arm, that is trastuzumab docetaxel of the Cleopatra. So, important question that we must answer in our setting is that how many of our patients have access to pertuzumab? And if you don't have access to pertuzumab, that means you are left with a choice of Trastu plus endocrine versus Trastu plus chemo. Trastu plus endocrine is not a bad option. There is one randomized control trial which has shown it is PFS is longer than similar outcome from TRAS2 plus chemotherapy. Next. What about guidelines? If you go through the guidelines, it is very surprising that even though there is not much data, the latest NCCN guidelines for a triple positive metastatic breast cancer gives both the options of trastuzumab plus endocrine as well as trastuzumab plus chemotherapy. In fact, all the trastuzumab plus various endocrine partners are recommended regimens if you go with the NCCN guidelines. Next. Now, in a recently concluded ASCO, there is an ASCO educational book. There is this particular chapter published, systemic therapy for HER2 positive metastatic breast cancer, moving into new era. I had a discussion with the author Dario, the second author of the particular article, and they also very clearly mentioned that a lot of guidelines give this particular option of trastuzumab plus endocrine therapy, and it can be considered in a select population, especially those who are not fit for chemotherapy or those who have only bone-only metastasis. So there is a significant literature available for this particular approach. Next. So to conclude, I feel trastuzumab plus endocrine is a less toxic and reasonably effective option, especially in our setting when pertuzumab is not available due to cost issue. De-escalation should be tried in triple positive metastatic breast cancer. It is a fashion or the latest trend in a HER2 positive HR negative metastatic breast cancer, but it is not the trend in a triple positive breast cancer. Some patients can be outliers and may do well with de-escalation, and hence I feel this can be used in those patients with bone-only mets, elderly, not fit for chemotherapy, and not with significant visceral mets. Thank you.
Dr. Krupa.
Sure, sir. Just share my screen here. Well, hope my slides are visible and I'm audible.
Yes, sir.
Are my slides visible and am I audible?
Yes.
Okay, thank you. So a very good evening to everyone. And before I begin, I must take this opportunity to thank the organizers for the opportunity, and especially Dr. Sahu sir for putting me into the spot. But I must say, I must congratulate my colleague opponent as well for putting up a damn good fight. But I'm sure he himself, like he rightly alluded to, I think this debate is not about patients who are not fit for chemotherapy, because then obviously the answer is you're not going to give them chemotherapy. So I think, if we're talking about patients who are actually eligible for both the options, I think that's where the focus of the debate. And I won't be reading too much into a single institution phase 3 Chinese data either. So as far as I'm concerned, I think, as far as I'm concerned on this issue, there's absolutely no debate whatsoever. So let's look at the split up of patients with triple positive as opposed to only truly HER2 enriched. I think 50% get ruled out straight away there itself. You're only going to talk about 50% of patients who have the triple positive disease, and that's what we're going to debate upon for today. So I think, what about the biology? I mean, you heard my colleague also talk about the cross-talk between the ERPR and the HER2 pathways. Let's not forget that, that's one of the primary reasons for endocrine resistance. So obviously, that to me is a basic fundamental flaw in the hypothesis. So are we trying to promote endocrine resistance by doing that? So I'll touch a little bit more about that as we move along. And what have we learned from history? I think this is what a lot of work done by Dennis Lamb et al., where chemo with trastuzumab as opposed to chemo alone. Look at the median OS, 25 versus 20 months. And the early data that we saw only spoke about PFS. I'm not sure what the OS data is there. So I think this is, again, a famous quote from Winston Churchill: those who fail to learn from history are doomed to repeat it. And again, if you look at multiple choice of chemotherapy partners as well, it's not just docetaxel alone, paclitaxel as well. And again, you can see that the median OS well over 1.5 years, or close to 22 months. So what about combining a dual HER2 blockade? I think that is where the best possible combination. We know about the homodimerization and heterodimerization and how the downstream signaling pathways are blocked better. And that provided the rationale for this dual HER2 blockade with chemotherapy backbone, which is the Cleopatra study, which is absolutely the standard of care, as my colleague also rightly alluded to. Let's look at the updated survival results. Can you match that? We were just talking about 19 and 12 months of PFS, but look at the overall survival, close to 5 years. And that's fantastic. I don't think we have any data up until right now to match that unmatched survival in this setting so far. So an absolute improvement of around 16 months. And that to me is the gold standard. And I know my colleague was harping on the adverse events, but let's look at putting things into perspective. Let's look at the grade 3-4 adverse events. Neutropenia, 49%. But look at the febrile neutropenia rates, hardly only around 13%. And grade 3-4 diarrhea. Let's not talk about 60% patients had diarrhea. It might be on a grade 1 or 2. Let's look at grade 3-4 diarrhea, only 9%. That to me is not a major area of concern. And again, if you're really worried about your choice of chemotherapy backbone, you always have the data to use, again, your investigator's choice of taxane, which could either be nab-paclitaxel, or docetaxel. And look at the grade 3-4 adverse events. They seem to come down much better. So toxicity, absolutely not a concern for me. No toxicity. And again, you could also use vinorelbine with pertuzumab and trastuzumab. That's the data here based on the Velvet and the Hernata studies. Not going to get into those details. And this is again the same slide which my colleague had shown earlier as well. But let me remind you that because of this crosstalk between the ER alpha subunit and the HER2 pathways through the IGFR pathway as well, it can actually turn tamoxifen from an inhibitor to a stimulator of breast cancer cells. And we know that's a selective estrogen receptor modulator, which means it's a partial receptor antagonist and an agonist. We know it's an antagonist in the breast tissues. So what happens because of the crosstalk is that it can have an agonistic effect in the breast tissue, thereby promoting primary endocrine resistance. So that to me is a basic fundamental flaw. So let's look at the data. And I'm surprised that my opponent chose not to focus on these studies as well. The tandem study, which looked at anastrozole, trastuzumab versus only anastrozole again. Look at it, median PFS, 5 and 2.5 months, and median OS only around 28 versus 24. Very disappointing. So are you kidding me if you think that you're going to go up against the Cleopatra daddy? So let's look at lapatinib plus trastuzumab. Again, didn't seem to do too well either. Look at that. The overall survival here being 14 versus 9.5 months. So I think, you seriously got to be kidding me when you say endocrine therapy with a trastuzumab backbone should be the first line choice of therapy. And let's look at even the cross-trial comparisons. Let's look at the EGF data, the ELECTA study, which is another study looking at letrozole and lapatinib, and the tandem study as well. PFS ranging from 5 to 8 months. Think that's good enough? I don't think so. And look at this. This is just a cross-trial comparison between the Cleopatra and EGF. Absolutely nothing to choose from. I mean, you cannot compare. There's no comparison. Heads-on winner would be the Cleopatra. And this was another interesting study, the PERTAIN study, and remember, this was again phase 2 data only. Looked at a combination of dual HER2 blockade plus an AI. And this trial also allowed for induction chemotherapy to be used as well. Primary endpoint being PFS. Well, and let's not forget that this is just phase 2 data and also did allow for use of induction chemo as well in a subgroup of patients. And despite that, the median PFS was only around 18 months versus 15 months. So there, to my opponent, I would say, is that the best that you've got? And let's look at one more data. This is the phase 3 data again called the alternative study. And as the name rightly suggests, it's only an alternative to patients who are not fit for chemotherapy, elderly patients, very low volume of disease, and probably only an alternative only in that subset, but not in patients who are fit for chemotherapy. And let's look at the overall survival as well here, 46 months. Again, nowhere close to the 57 months that we saw in the Cleopatra data. So to me, I think heads on, we have a clear winner. And I know probably my opponent might say it's better than the alternative, but then again, it's an alternative only in patients who are not fit for chemotherapy. And again, my opponent did talk about the NCCN guidelines. Let's look at it. Let's look at it in detail. Look at it. All the preferred regimens with a level 1 category of evidence are for chemotherapy with a dual HER2 blockade. So I don't see an endocrine therapy with that coming into the picture here at all. Probably it might be in the other recommended regimens, but I don't think that's anything to go by. Category 1 preferred regimen definitely is the chemotherapy backbone of dual HER2 blockade. Sorry, that's the rule. Those are the rules of the house. So to conclude, I think, as far as the rationale is concerned, I think there's a fundamental flaw in the rationale and the hypothesis. We know about I've already touched upon how it does promote endocrine resistance because of the crosstalk between the ER and the HER2 receptors. And what about earlier data like the tandem EGF ELECTA? Absolutely disappointing results. I don't want to even discuss or talk about it. PERTAIN data, again, it's only phase 2 data. And remember that induction chemotherapy was used as well. An alternative, absolutely truly remains only an alternative as well. And the authors also concluded by saying that it's an alternative in patients who cannot or cannot go on chemotherapy or not fit for chemotherapy with a low volume of burden of disease and bone only metastasis. So I think patients who fit for chemotherapy, absolutely, that is the gold standard. And with dual HER2 blockade, Cleopatra remains the standard of care. Toxicity is not a concern with only a finite duration of chemotherapy, and we have alternative chemo drug combinations to choose from. So with that, I think that's Cleopatra saying I'm done. So I think, with that, I'll rest my case.
Dr. Amol, any 1 minute coming back
Yes.
at him?
Yes. I think my dear colleague has forgotten that the topic of the debate is trastuzumab plus chemo versus trastuzumab plus endocrine therapy. It is not trastuzumab plus pertuzumab plus chemo versus the trastuzumab plus endocrine therapy. So that is the first point. Now, if you look at the data of only trastuzumab plus chemotherapy, as my colleague has showed, the PFS is hardly 6 months, 8 months, and in the previous slide that I shown, that is trastuzumab plus paclitaxel or trastuzumab plus docetaxel that I have shown in the control arm of the Cleopatra. So I still feel that in those patients who have only bone-only metastasis, especially in our setup when pertuzumab is too high costly, we cannot forget while having debates in India that we still belong to low and middle income class country, LMIC. And in that, probably trastuzumab plus endocrine therapy will be still a good effective option, especially the disease burden is not very high. So I think we should leave pertuzumab out because the debate is not between trastu. It is between trastu endo versus trastu chemo. There is no question of pertuzumab coming in between.
Just one simple question.
Yeah. Do I get my 30 seconds of shot as well?
Yes.
Just one simple thing.
Sure. Please, Dr. Sahu.
Just any patient, even if it's affordable class, in this triple positive, money not a concern, would you ever consider hormone therapy with HER2 targeting?
No, I think if the patient is fit for chemotherapy, I wouldn't definitely look
even
at
with 4 bony mets and 1 liver.
Yeah, even in that case, I think, my rationale is very simple. I think, even while going ahead with chemotherapy, we know it's only for a finite duration. You're not going to keep on giving chemotherapy forever. It's going to be for 6 cycles, and then you're going to put them on endocrine therapy any which ways. So I'd want to get that response out of the chemotherapy as well. And and also, if you look at the data, I showed you the historical data, even from Dennis Laman et al. The median overall survival is around 25 months, 2 years. And the Chinese data, I don't know what the overall survival is because my colleague has not mentioned about the overall survival. We are only talking about PFS and in a single institution, Chinese data. I'm not aware of any other data. And I did show you the data for all the single where only trastuzumab was combined with endocrine therapy alone, tandem, EGF, Electa. Absolutely disappointing results. I don't think my colleague ever answered to that question. What about the tandem, Electa, EGF?
Okay, so time out. And
yeah, sure.
I think both of them have their points. And I think in the Indian scenario, the hormone and trastuzumab does make a viable option, especially for the low volume disease. But in a patient who is fit for chemotherapy, has a high disease burden, especially visceral, it does make an option. But with this Chinese data, at least this becomes a level of evidence which you can speak with the patient. That's how take it. Before that, we did not have much of an option to discuss this, and chemo plus HER2 used to be the normal way to go ahead. Can we take this as a take-home message, Amol, from your side?
Yes, definitely. Okay. If there is a less tumor burden, one should consider that, especially pertuzumab, if it's an issue to use pertuzumab.
Okay, so now we go to the panel discussion, and I invite Dr. Sendil Rajappa, senior consultant from the American Cancer Institute, Indo-American Cancer Institute from Hyderabad. And before I'll invite the panel and he can answer this question, what he feels about the Chinese trial in half a minute, and then I take to the panel. The panel will be Dr. Biswajit. He's from JIPMA, Dr. Manshi Shah from Ahmedabad, SCG, Dr. Deepak Shukla from Manipal Hospital, Jaipur, Dr. Rohan, he's a surgical oncologist from Gurgaon, and Dr. Ashish Joshi, Mumbai.
Hi, Sagu. Good evening, everybody. Thanks so much for asking me to do this panel. So we are 7:15 now, so 7:40, Sagu. Is that right?
Yeah, it is okay. Half a minute extra for you for what you think of the Chinese trial.
Oh, my take on the Chinese data, I very much agree with Amol. So, we always throw Chinese data away, through the window because they're Chinese. But I think there's some, at least from an academic standpoint, it's important to consider that. And your conclusion was absolutely appropriate, that in selected patients, it's important to consider anti-HER2 therapy plus hormonal therapy. So that's very important. I do it routinely in my practice. So we all have the data, but all of us know that not everybody needs chemotherapy, isn't it? So that's the way I would look at it.
Okay, please carry on with it.
Great. So I've been asked to do a panel on early breast cancer, which is triple negative or HER2 positive. So there isn't enough time to look at both of these phenotypes. So we'll kind of flip-flop and then have some fun in the next 20-25 minutes. All that I'm going to show is day-to-day patients that we routinely see. I've not got anything out of the box or something out of the way that we will discuss. These are patients that we will see every day in our practice, and that's what would make this hopefully make this panel interesting. So here's this first case: a 35-year-old lady married a year ago. Breast lump on a screening mammogram. So don't ask me why they did it on a 35-year-old lady. It was done, and that's what it is. No lymph nodes on the ultrasound. So it's a clinical T1N0. Let me start with Dr. Rohan, the surgeon. Dr. Rohan, any additional local imaging that you would ask in this patient, a 35-year-old lady?
I'm assuming the mammogram would be of a dense breast in a 35-year-old. So if she's keen on breast conservation, I would do an MRI here to help my decision regarding a breast conservation for her.
Excellent. So, Dr. Rohan, just another practical question. We keep discussing this in our tumor boards often. When you find a suspicious lesion on an MRI, but that's not localizable on an ultrasound and that's not clearly biopsiable, how do you deal with that situation, Dr. Rohan?
So again, we've also had these discussions multiple times in our surgeons forum. And I repeatedly say that to have a good link between your radiologist and the surgery department is very important. So if you have a dedicated breast radiologist who's routinely looking at these scans, then they can tell you that, this looks suspicious, this you should do a J wire and remove it along when you're doing the surgery, or this can be left. So I think so. It's teamwork, and having a good radiologist, a breast radiologist, is of paramount importance here.
So wire localization is still possible, Dr. Rohan. The reason why I'm asking is we can't get into the MRI with the wire, isn't it? So if you're not able to localize it on the ultrasound, what's the practical way of managing?
So MR guided biopsies are also being done. Like I do a lot of vacuum assisted breast surgeries, VAB procedures. So MR guided VAB biopsies can also be done.
Correct. So that's not very commonly available, isn't it? So that's the reason why I was asking you this question. So, we end up doing an MRI for all these patients, and then they come back to the tumor board, and then we are stuck with, how many localizations and how many small wide local excisions one should be doing. It's always a difficult problem. I entirely agree with Dr. Rohan. So,
although,
go ahead, Rohan.
If I can just add one more point, we actually get a mammogram done for all the patients, even if they are young. And as breast surgeons, it would help us because it helps us with when we have to do our oncoplasties. It tells us if there's adequate breast tissue there, our oncoplasties become much easier than a fatty breast where the mobilization becomes very difficult.
You're actually right. So we would also go and do it. But the reason why I said a mammogram is we wouldn't do a screening mammogram.
I agree.
All of us generally do a contrast enhanced mammogram because some of our radiologists believe that a contrast enhanced mammogram is nearly as good as an MRI, not definitely as good though. So that's something that we do in practice, at least in our hospital. Excellent. So we will get an MRI done to localize. Excellent. So we did a biopsy. It's a grade 3 invasive carcinoma. Triple negative disease, and the Ki67 is 65%. Deepak, would you do neoadjuvant therapy or would you send this patient for surgery? 1.3 centimeter.
No, I'll prefer upfront surgery for this patient.
Okay, you will prefer upfront surgery, right? Ashish, you would also prefer upfront surgery?
Yeah, so upfront surgery becomes a reasonable option here. Having said so, there may be there are institutes which still perform a neoadjuvant treatment for a T1C disease like this. And that's not entirely wrong. Especially many of the US institutes do it for a triple negative breast cancer, considering the impact of the PAT-CR and so on and so forth. But yes, I agree with Deepak that probably surgery would be a reasonable option in this case.
Absolutely. So I think you you actually brought in the very important point of whether you should be doing neoadjuvant therapy and looking for PAT-CR in this, and then trying to escalate therapy if necessary. Dr. Mansi, what would you do? Ashish brought up a very important point. So there are situations where in T1C, those borderline patients that based on imaging, clinical assessment, we're not too sure, and then we err on the side of doing neoadjuvant, and then we find that even if they were T1C, when they had surgery, they don't achieve a PAT-CR and they are candidates for escalation. So sometimes you come back and think, should I be doing neoadjuvant chemotherapy for these patients rather than taking them to surgery straight away? What is your thought, Dr. Mansi?
Good evening, Dr. Senthil. So I feel like for patients who have T1C disease, chasing PAT-CR might not be the right way to go ahead. Escalation of therapy for such small tumors, I'm not sure how much extra benefit, it might be, if we are getting any extra benefit, to be very honest, for such small tumors. I know there's data for or institutes that do it for anything more than 0.5 centimeters, but I'm not still convinced.
Okay.
So T1C, I still go for surgery.
Excellent. So we could go for surgery. Absolutely nothing wrong. So you made a very important point that the recurrence in patients who don't get a PAT-CR will also depend upon the T stage at the time of diagnosis. The same is the case for patients who get a PAT-CR also. The larger the tumor that you start with, in spite of a PAT-CR, you can still have a higher rate of recurrence. So I think you both Ashish and Dr. Mansi have brought out very important points. One is the potential role of escalating your treatment post-surgery based on a PAT-CR, or rather not achieving a PAT-CR. And also your point that the benefit of escalation may be doubtful. We don't know, but all of us tend to end up doing surgery in patients with, T1 disease, irrespective of whether they are T1A, B, or C. Dr. Rohan, what is it that you practice in your institute? Do you send them for neoadjuvant? Because that's, as Ashish said, one of the options, at least in North America.
So if it's a T1, T2 lesion which is amenable to a breast conservation and the patient is desirous for it, I will take up the patient for surgery upfront, provided that the nodes are negative.
Okay, provided nodes are negative. So our medical oncologist will be a little upset, Rohan, if you said that for T2 you wanted to do upfront surgery. Biswajit, are you upset? You're happy with Rohan?
So if it's an early T2 and if breast conservation is possible upfront, I would take up the patient for surgery. If it's a T2N0, early T2N0, I'm not saying if it's close to 4 centimeters or so.
Dr. Mansi, 2.1 centimeter on the mammogram. Surgery, 2.2. Where would you say chemo should come first? So we should draw a line somewhere.
I think I draw the line, if it's anything less than 2.5 centimeters or
okay,
even close to 3 centimeters, I'm fine.
Okay,
anything more than 3 centimeters, definite neoadjuvant.
Okay, for us, we are a little bit sticklers to, so-called guidelines. So for me, anything more than 2 centimeters, we would end up doing neoadjuvant chemotherapy. But, you can never draw a line. You can always argue 2.1 on the imaging, is it right or wrong, right? It depends upon how the radiologist has measured it, and Rohan clearly made the point that your radiologist is extremely important. So these are some gray areas. There are no right answers. So I think we end up using our judgment at the end of the day, discussing with our patients to, get this point sorted out. Very good. So for me, anything more than 2 centimeters, I clearly do neoadjuvant therapy. But you're not wrong if you did neoadjuvant for a T1C, nor if you didn't do neoadjuvant therapy for a 2.5 centimeters. So we leave it there. So this patient underwent wide local excision sentinel lymph node, 1.1 centimeter, no LVI, PNI, margins negative, N0. So Biswajit, adjuvant therapy for this patient?
So at our center, what we do is for yearly lesions, especially for T2N0, up to T2N0, we do the Paclitaxel carbo. That is the weekly Paclitaxel carbo for 8 cycles, 6 cycles or 8 cycles. I think it's 6 or 8 cycles as per that study, which was a randomized study between avoiding anthracyclines in that subset. So, but there is a problem with this that we discussed this option. The problem is with the neuropathy, because as per that study, it was the number of cycles were high, and the neuropathy is an issue with that protocol. So that is what I would do. And with capecitabine,
we'll come to that. We'll come to that, Biswajit. So that's very interesting. So Ashish, you unmuted yourself. I think you want to say something. So your comments on Paclitaxel as the adjuvant therapy for somebody like this, Biswajit is certainly quoting some data, but would you say in a 35-year-old lady with 1.1 centimeter T1C typically needing adjuvant, you would want to use an anthracycline taxane containing adjuvant chemotherapy, or would you downscale it to a non-anthracycline containing one? We'll come to the carboplatin story a little later.
So I would not use carboplatin adjuvant setting for a triple negative. I would still continue, though it's a anatomically it's a small disease, it's a biologically aggressive disease. It's a triple negative breast cancer in a young female. So I would go with standard anthracycline taxanes combination.
Okay,
So
Mansi, anthracycline taxane.
I agree with Dr. Joshi. I would go with the ACT.
Okay, so anthracycline taxane, some kind of anthracycline taxane, is that right?
Yeah.
Yeah, Biswajit, please go ahead.
Yeah, so this data comes from a phase 3 study. You have a phase 3 randomized data
Absolutely,
of
absolutely.
Yeah.
Absolutely. But the design was a little
really
unconventional. The design was a little unconventional, as you were rightly pointed out. But where do I do Paclitaxel only as adjuvant or neoadjuvant? Somebody who's elderly, and in my so-called judgment, I think that lady is not a candidate for anthracycline containing chemotherapy.
Cardiac toxicity. So we
yes,
could
I'm
avoid
coming to that.
toxicity in this study.
So in a 35-year-old, yes, cardiotoxicity is a concern at all ages, but in a 35-year-old, though it's a concern, it's not a big concern. So that's the reason I was asking you. If it was a 65-year-old lady with hypertension, then I would, certainly, I have done this many times, just did weekly Paclitaxel for 12 weeks in patients who need neoadjuvant or adjuvant therapy for triple negative cancer, whichever way it is. So I've certainly done that a few times. So yes, but the standard would be an anthracycline taxane containing. Deepak, would you do capecitabine adjuvant? We're not talking about escalating therapy based on a pathological complete response. We're talking about a patient who had upfront surgery. Let's say Rohan did surgery and then it came to you 1.1 centimeter. What would be your thought? Let's say the same patient had a 3 centimeter tumor and you did your anthracycline taxane. Is there a role for low dose capecitabine for a year?
So, sir, there is some data for showing DFS benefit for means adjuvant capecitabine, but again, for 3 centimeter, possibly in a young patient who has multiple nodes positive, possibly in that subset, I'll consider adjuvant capecitabine. And in addition, now we have data for Olympia where we do BRCA1, BRCA2 testing. Possibly for a 3 centimeter tumor, if it is BRCA positive, then olaparib
that there's a 10-11% improvement in the disease-free survival, something that's much higher than many other interventions that we would discuss in medical oncology. But for some reason, it's not been a very popular intervention. So most of us would stop with chemotherapy. Mansi, would you use adjuvant capecitabine in a 3 centimeter tumor post anthracycline taxane containing chemotherapy?
So you're saying
upfront surgery, 3 centimeter tumor, PT2N0, PT2N0.
No.
Okay, so you're not impressed with the Chinese data. In fact, Deepak said that he would be tempted to do something like that in a node positive patient. Actually, the subset analysis showed that patients who had node negative disease were the ones that really benefited. So paradox, but that's something that's not been very popular, even though it's low dose capecitabine, something that is very, very suitable for patients from our country. Yes, Biswajit, you wanted to say something.
I differ from this is that the CSEC trial, which is that Chinese trial, which had 10%, in fact, had included 65% of the patients who are early stage node negative disease.
Yes, exactly.
And they had shown a 10% difference in the DFS. I agree there is no overall survival benefit. And the dose is actually a metronomic kind of schedule. So it's actually the dose is much lesser. It's 625
600 per meter square. It's 600 per meter.
So actually, it's on a continuous basis and quite a tolerable regime. So in a triple negative, where we actually on a relapse, we do not have much of an option. That study seems to be quite interesting. So I put my patients at least on.
Very good, very good. I think that's a very reasonable choice, and you quoted the study very nicely, Biswajit. Exactly. So if you looked at the forest plot, typically patients who are a 2 centimeter, 3 centimeter tumor, those were the patients who actually benefited. But that's an unblind subset analysis, so we will not go reading too much into it. But the fact is that there is data to do adjuvant capecitabine post your chemotherapy for patients with upfront operated triple negative disease. So that's what. Mansi, you wanted to make a point. You're unmuted, I see. No?
So I think for patients whom we feel like they have a very high risk of disease, for some reason, if somebody's done upfront surgery for multiple node positive, then I think it's reasonable for node negative. No matter how low the dose of capecitabine is, I think it's still not a very good, easy drug to take for most patients.
But I don't know whether Amol is still there. He may not savor this statement very much. He's a fan of capecitabine. I've spoken to him a few times.
But we have a clear-cut randomized data.
Yes, absolutely. I think we'll give everybody their personal opinion. So that's
Dr.
why I said,
Senthil,
simple things are controversial. Yeah, Sahu, go ahead.
Yeah, just a minute. With this Chinese data, there's one data which is showing in the T1, T2, N0, which was 90% of their patient lot. They still found a 10% distant disease-free survival. And it is not much of a cost. And we have been changing therapies on 2%. So why are we so reluctant to this change?
So all the people who are reluctant, I am the moderator, so I don't want to say whether I'm reluctant or not. So people who are reluctant, please answer Sahu, the boss. No, Sahu, I think, the reason is we haven't adopted capecitabine to its real strength in our practice is what I feel. That's because trials have been all over the place. They have not been consistent. And then there is some data regarding whether basal versus non-basal, which of these patients actually benefit. So the consistency, or rather the lack of consistency with capecitabine has been the bane of capecitabine, I think. Though there is a nice meta-analysis in the early setting showing that there is even an overall survival benefit, all of these trials put together. But since individual trials have not been very consistent in the benefits that they have offered in this setting, many of us are still very hesitant to use capecitabine. So that's what I would feel as the reason for many of us not adopting. Not that we don't believe data.
One more question
Yes,
for the
please.
first data which you showed for Createx. Let's say the T1 tumors and T2, T3 tumors, the hazard is nearly the same. It's 0.665 or 7. So where does this cut off for giving neoadjuvant and the advantage of capecitabine? So why would you not give that extra advantage?
Exactly. So that's what I'm saying. So Sahu, I think we should not read into that subset analysis too much. So the point is that whether you consider a small percentage of patients with a T1C tumor who may not achieve a pathological complete response, and if you believe that that group is going to benefit by escalating the adjuvant therapy to capecitabine, then you should surely go ahead and do it. But if you strongly believe that if you start with a T1C tumor, then the value of achieving a pathological CR might not be as good as or as bad as achieving it in a higher stage tumor, that's controversial, then as Mansi said, you may not want to use it. So I think it's your point is absolutely right, that the hazard is same. If you don't achieve a path CR, your likelihood of getting the tumor is higher. Even if you get a path CR, you still are likely to get it, but the chance is lower. So if you believe that escalating is going to benefit your patient with the T status that you're starting with, then it makes a lot of sense to do neoadjuvant therapy. Your point is absolutely well taken, but that is a gray area which everybody has not started following yet. So that's the way I would look at the controversial role of neoadjuvant in a TNBC that is T1C. Right?
May I just make a point, Dr. Senthil?
Yes, Mansi.
I think for these patients, where we're thinking of escalating therapies, the role of circulating tumor cells, I think it will be very important. Trying to figure out which patients are more likely to relapse is my personal opinion. I know we're not there yet, but I'm hoping that we kind of get there at some point.
Absolutely. So at some point in time, yes, but then, when you're going to start neoadjuvant, the value of circulating tumor cells might be a little lesser. So if you've done upfront surgery and then you've got a borderline situation wherein you're not decided about adjuvant chemotherapy, then circulating tumor DNA or circulating tumor cells might probably be of use in a setting like that. Right. So that's what I would think. Okay, great. So let's move on. We've got 7 more minutes to go. I will hand it over.
Can I just quickly make one point, please?
Yes, Rohan, please, surgeon.
So you said this was a 35-year-old lady married for just 1 year. So I'm sure she must be thinking about fertility preservation as well.
Yes. Yes.
What if she had a tumor which is say 2.83 centimeters? In that case, would you be comfortable waiting for at least a month till the fertility preservation cycle is done? Or in that case, are you fine with the surgery being done during that period and then going at the chemo?
Okay, Rohan. So nowadays, our infertility specialists or fertility specialists, whatever you want to call them as, are able to get that oocyte harvesting done in 10 days, Rohan. So it's
10
not
to 15
1 month.
days. Yeah, I mean,
correct. So I think if you believe that neoadjuvant therapy is important and escalation is important, and so on and so forth, and in a patient like this, you always would like to get the BRCA testing done. And then, you have to break your head counsel and, surgical issues that would complicate and so on and so forth. For me, if I think neoadjuvant therapy is important, then I certainly send them, I try to counsel them. There are always patients who say, let's get on with the therapy tomorrow morning, doctor. And I don't want oocyte and business, all those things like that. But wherever possible, I think we should be able to send them a week, 10 days to get their oocytes harvested before we do it. That's what at least I do in practice.
Thank you.
Okay, great. So we'll get on to the second case quickly, 5 minutes to go. 45-year-old premenopausal lady with the right carcinoma breast, T2N1, a single node on the ultrasound, FNA was positive. Breast can be conserved with upfront surgery. A biopsy was done. Grade 3 tumor, ER is 9%, PR is 8%, HER2 is negative. Ki is 67, is 70%. She's a BRCA2 positive germline. So Ashish, is this to be treated like triple negative disease, or is it to be treated like hormone receptor positive disease?
So this appears to be biologically proximal to triple negative breast cancer.
So what would be your approach be in this patient?
Certainly neoadjuvant chemotherapy, no surgery. It's a T2N1 disease. I would be tempted to use taxanes, weekly paclicarbo.
Correct. So where from the platinum evidence, Ashish?
Correct. So yeah, I mean, it's a gray zone and could be a contentious issue, but there have been reports wherein if you add platinum to a BRCA positive breast cancer, TNBC, then there is obviously pathologically improved PAT-CR, which is probably would reflect into invasive disease-free survival benefit.
Okay, so the pathological complete responses are higher in patients with BRCA positive disease. So that's something that we always assume, Ashish, but if you really look at the data, the difference between the BRCA positive versus the BRCA negative in terms of pathological complete response with the platinum drug is not very different in terms of statistical significance. Numerically, you're absolutely right that the group with BRCA positivity is likely to have more pathological complete responses. Sahu is asking PARP neoadjuvant therapy, Mansi PARP neoadjuvant therapy.
So this data with single agent PARP inhibitor, I'm sorry, I'm not able to quote the study, with significant PAT-CRs, I think close to like 30 or 40%. So it's pretty interesting. I think we need like a little bit more data and a little bit more time, maybe having another study which is positive for single agent PARP would probably push me towards using PARP just for neoadjuvant and quitting chemotherapy.
Okay, because she's
but
BRCA
as of right
positive.
now, I don't use it.
Right, excellent. So our Bharat Vaswani has quoted the brightness study. So, I always feel, we've just taken the brightness so easily. So the interesting point about the brightness was never designed to compare carboplatin containing regimen versus a non-carboplatin containing regimen. In fact, it was not planned. It was not part of any statistical plan at all as far as the brightness was concerned. But when they did the analysis and then showed that the hazard ratio is 0.63 for patients who took platinum compared to patients who did not take platinum, we just, swallowed it without any difficulty and then said, based on the brightness, I want to start using carboplatin in all my patients with triple negative disease. Nothing wrong in using, but I'm just trying to say the flimsy evidence based on which we have quickly jumped into the carboplatin bandwagon. It's very relevant for our patients because it increases the PAT-CR rates for whatever it's important and it's relevant. and it's cheaper in our patients. But please remember that, if you've used a lot of carboplatin, you also will have to keep a watch on the marrow toxicity. It is sometimes difficult to use. You may end up compromising the dose of the taxane, which is something that we should not be doing when you're using carboplatin also in these patients. So yes, it's nothing wrong in using carboplatin, but please be cognizant of the level of evidence that is available and the fact that it can compromise the dose of the taxane, which is something that we don't want to do. Excellent. So Mansi, Pembro or not? This is a biological triple negative disease masquerading as an ER positive disease. So would you want to use pembrolizumab in this patient, neoadjuvant versus not?
So I think there's definitely data, and there's updated data with event-free survival improvement in using pembrolizumab with the Keynote 522 study. So I would definitely counsel this patient.
You will definitely counsel.
Patient, premenopausal patient, node positive. So yes.
So essentially, Biswajit, so we are agreeing that if ER is 9 and PR is 8, we should be treating this lady as triple negative disease. Is that right? Because none of the studies that took patients, at least in the earlier era, nowadays patients like this would also be enrolled, and patients like this would not be enrolled in a patient, in a population of ER positive patients. But in the era that the other studies were started, these patients were excluded from these studies. So Biswajit, yeah, make your point.
Yeah. So if you go by definition, more than 1% has to be taken as hormone positive.
Correct.
So if you can put it in the Aldred score, also it would be better. That is the method by which you would put. But anyway, more than 1% hormone is taken as hormone positive. So then why do we need to tell this as triple negative? I'm not able to understand. So
we're not saying this. We are just saying that is it biologically? So Ashish clearly said that.
Does not matter whether it is biologically different or not, because ultimately at the end you would still give hormone therapy.
Exactly, so I'm coming to that point. So you've got so many other choices that you can actually do in this patient because time is up. So there's hormones or not, and then there is abemaciclib or not, BRCA2 is positive, olaparib or not, capecitabine or not if you can't afford many of these things, and so on and so forth. So many other questions will come up now, Biswajit. Nothing wrong, it should come up. So that triple negative disease, though you would not necessarily classify this as triple negative disease. So when we look at the management of somebody like this, we would definitely consider using regimens that are used in patients with triple negative disease. But at the end of all this treatment, as Biswajit rightly said, because anybody who's got 1% or more, there is data retrospectively to show that they benefit from hormonal therapy. You would also end up using the hormonal therapy at the end of all this triple negative story. So this is not an uncommon situation, and I think at the end of the day, you would probably have to individualize how you
Would we do a
you know
gene
approach
profiling?
these.
Would you do a gene profiling or something to make sure that it is
So
actually?
you're talking about intrinsic subtypes, Biswajit, but the
No,
problem
I
is
understand. But if you
intrinsic
get an
subtypes are
intrinsic
not
subtype like
commercially.
this, where you have a, when you have an
In-
intrinsic subtype where you have a confusion like this, would you want to go in and actually do a gene profiling and make sure that they are actually having
Ideally,
a
the
triple
future
negative
should be.
signature rather than a hormone positive?
Ideally, the future should be that if there's anything in the gray, you should end up getting an intrinsic subtype done before you do treatment, but we don't have prospective evidence to say that approaching your patients like that has given better outcomes compared to doing that conventionally. Even in patients, in the metastatic setting, there's a lot of data looking at intrinsic subtypes. You will see that about 20% of these patients whom you think are HER2 negative are HER2 enriched when you do the intrinsic subtype. About 5 to 6% of patients are basal, so they're actually triple negative. Maybe a patient like this is what would end up being classified as triple negative when you do the intrinsic subtype. But essentially, you're right that patients who fall into the gray area, like what you're looking at in this situation, should ideally have an intrinsic subtype before you decide on what you want to do. Thanks, Saho. I think we've looked at. So you see that the most common cases are the most interesting ones when you talk to people, because everybody has their own way of approaching these problems, and that's what I think makes these common problems more interesting than the most uncommon things that we end up discussing in many of our panels. Thanks so much, all panelists, and thank you.
Thank you. Thank you, all the panelists.
Thank you.
Dr. Sendil. And this could have gone on for another half an hour with the debate still continuing. And this is something the beauty of when Sendil does it. So thank you, all of you. So we move on, and I think I'll go on to invite Dr. Vinit Govind Gupta, medical oncologist, senior one from Artemis Hospital, Gurgaon. And for the next 20 minutes, we'll be having a transformation of paradigm of HER2 positive breast cancer treatment, a flexible future. Vinit, request to stick to time, please. You're there, Dr. Vinit?
Okay, I'm sorry, I was muted. So good evening to everybody, and thank you, sir, for the introduction. So we're going to discuss the new treatment modality in HER2 positive breast cancer, or rather the new mode of delivery in HER2 positive breast cancer patient, which is the subcutaneous preparation of pertuzumab and trastuzumab. And disclaimer that some of these slides are provided by Roche. So currently there is the pertuzumab, which is a anti-HER2 antibody utilized in combination with trastuzumab. It has shown its efficacy in various settings, mainly in the neoadjuvant setting for early breast cancer and the advanced or metastatic setting. In addition, affinity data is there in the adjuvant setting as well. So the current paradigm, there are ways to integrate this drug in various settings. So for smaller tumors, you might want to go for surgery first and consider some kind of adjuvant HER2 therapy. While for larger or node positive tumor, you want to start with neoadjuvant chemotherapy with pertuzumab, trastuzumab, followed by surgery. Nevertheless, there is a need to, the one unmet need is to optimize the delivery of antibodies, because giving these antibodies as an IV infusion, it takes more time towards the patient. It increases cost, increases daycare burden. There is a need for long-term IV catheter placement, either a PICC line or a chemo port. And for some patient, they may not want to go for a IV access. So to overcome this limitation, this new product has been developed, which is a subcutaneous preparation containing pertuzumab and trastuzumab. And the main ingredient is actually recombinant hyaluronidase, which allows subcutaneous administration of larger volumes. So the major limitation has been that you need to deliver a large volume of drug, which is not possible without with the conventional approach. So what recombinant hyaluronidase does, it increases the dispersion of the drug, and it basically increases the permeability of the subcutaneous tissue by depolymerizing hyaluron without affecting the underlying basic structure of the subcutaneous tissue. And usually it reverses, the effect reverses in 24 to 48 hours, by which time the drug usually gets absorbed. So just to describe the mechanism, that by adding hyaluronidase, it degrades hyaluron at the injection site, while the baseline structure of collagen and elastin remain the same. which allows the space to administer a larger volume of liquid, which can be absorbed by the body within 1-2 days. So, for example, if you use a large volume injection into the subcutaneous space with and without recombinant hyaluronidase, you can see the difference that there is a bleb formation which is not there if you are using this agent. So there have been the studies done by them to look at the pharmacokinetics, efficacy, and safety of this combination. So there was a dose finding study followed by a pharmacokinetic, efficacy, and safety study, which are Frederica and Francesca. So in the dose finding study, the dose which they selected was 1200 mg of Perjeta with 600 mg of trastuzumab as the loading dose and 600 mg with 600 mg as the maintenance dose. And the pharmacokinetics data and the safety data was agreeable, which led to the initiation of the Frederica study. So you can see the outline of the Frederica study. They have taken patients who are locally advanced or operable HER2 positive breast cancer, stage 2 to 3C, and they are randomized to 2 arms. Both arms start with anthracycline for 4 cycles, so AC for 4 cycles, followed by IV regimen of pertuzumab, trastuzumab with Pacli or docetaxel, and subcutaneous versus subcutaneous regimen of the same with paclitaxel or docetaxel, followed by surgery, followed by maintenance with the same 2 antibodies. So the primary endpoint is the cycle 7 serum trough concentration, with secondary endpoint include the various safety and efficacy endpoints. So just a bit of background. So if we talk about the difference between an IV infusion and a subcutaneous injection, there will be a difference in the absorption characteristic. In the IV infusion, you will immediately see the maximum concentration immediately after the infusion. So if you look at the green line, it is the kind of kinetics you will see with the IV drug. And until the next administration, it declines to a trough concentration, which is the concentration just before the next drug dose. While for subcutaneous dosing, what will happen is that level in the blood will increase over time as the drug gets absorbed from the subcutaneous space, and after which it falls until the next administration. And area under the curve is basically the net product of the concentration and time to give an idea of the total absorption of total exposure of the drug over one full cycle. So if you look at the primary endpoint, it was demonstrated that if you look at the trough concentration in cycle 7, it was non-inferior. So you can see that these with the IV and subcutaneous, the geometric mean of concentration is similar. And if we look at the pathological CR rate, which is a clinical endpoint, it was almost the same. So it was 59.5% versus 59.7%, which is almost identical. One important question will be that will the path CR rate change depending on the weight of the patient, because we are using a fixed dose and it is being given in the subcutaneous space. So actually, if you look at the small number of patients which are underweight, you can see that there is a difference of with 100% versus 43%, probably a consequence of the small number of patients. But in patients who are normal, overweight, or obese, overall the path CR rate are comparable. In obese, you can see that it is little bit more, that is 63% versus 48% in the IV versus subcutaneous. But in the overweight, it is reversed. It is more in the subcutaneous compared to the IV. So probably these are just chance observation. Overall, they seem to be comparable. And the adverse event, you can see that they are comparable. Most of them, the numbers are similar with differences in few percentage point only. So if you look at AEs, grade 3 AEs, serious AEs, death or discontinuation, you can see that they are similar or better with subcutaneous regimen. So even the various adverse event, they are similar. One important adverse event is the anaphylaxis adverse event. You can see that it is 2% with IV versus 1.6% with subcutaneous. So that is also comparable. But the fact that patient can have a chance of hypersensitivity and anaphylaxis means that observation time is still important, even when you are using subcutaneous regimen, and that is part of the guideline. Regarding the cardiac safety, you can see that the primary cardiac event, the incidence of cardiac event was low only. If you look at the primary cardiac event, which is heart failure and significant LVF decline or cardiac death, you can see that 2, 1, and 1 patient respectively had it in the subcutaneous arm, while it was 0 in the intravenous arm. While secondary cardiac event, which is defined as a drop of more than 10 percentage point to less than 50%, you can see that it was lower in the subcutaneous regimen, and overall LVF decline were comparable or lower with subcutaneous regimen. So therefore, they were able to establish the bioequivalence of these two regimens and similar pathological response in terms of pathological CR and similar toxicity in terms of toxicity profile. So they conducted one more study to look at the patient and physician preferences. And in the Francisca study, if we patient who were given both the regimen, majority of patients actually preferred the subcutaneous regimen, probably because the most common causes being less time in clinic and more comfort during administration. And in the continuation, the majority of patients wanted to get the subcutaneous regimen, and most patients actually were satisfied with the kind of regimen which they were getting. And even for the physician, it was found that it makes the administration time lower, and therefore saves time in the clinic and in the infusion room, and also reduces resource utilization. Adverse event, again, it was comparable with both the two regimens. And so just to summarize the patient preference study, most of the patients were satisfied or very satisfied, and overall there was good acceptability between patient as well as physician for this new regimen. So just to finish off, practically how to give this drug, and I have also given this drug in few patients and I have had a good experience. So patient need to sit back in a chair, and we need to expose the thigh. It is important that person who is administering is also comfortable while administering, because it takes some time to give the infusion. So if you change the position of the needle too much or the needle shakes too much, it is painful for the patient. So it is better if we also sit and are in a comfortable position before we give the injection. The site is the left and right thigh, which need to be alternated. Important is we don't give it in the abdomen. The characteristics of the product are such that ideally it need to be administered in the thigh only, and the injection site need to be separated by 1 inch. So if you're giving the third dose, it needs to be 1 inch away from the previous dose. You choose a healthy site of skin, and so there are 2 needles in the kit. You need to draw the drug with 1 needle and administer with a second needle, and you pinch the skin to create a subcutaneous space and inject it at an angle of 30 degrees, which is a standard subcutaneous injection. And if patient is having any reaction, we need to stop the drug. Otherwise, it can be given as a continuous. If patient is having pain, you can pause the infusion and the injection and resume when the patient feels more comfortable. And once the injection is given, the loading dose is given 15 ml over 8 minutes, and the maintenance dose 10 ml over 5 minutes. You need to observe the patient for 30 minutes for the first dose and the 15 minutes from the second dose onwards to make sure patient does not suffer any immediate reaction or hypersensitivity, and then patient can go home. So importantly, patient privacy is important, because the administration site is the patient thigh. So either you choose a separate room or you use good curtains before administering, and make sure that female attendant is present if a male nurse is giving the injection. So just to conclude, it is a regimen which reduces the administration time and observation period. It also reduces the need for a venous access, and studies have shown that not only does it have comparable safety and efficacy, but also good acceptability for patients and clinicians. So with that, we'll complete this presentation, and thank you again for the kind invitation.
Thank you, Dr. Vineet. Thank you for that lecture. And it was good to know how to administer the drug. Most of us knew the other scientific details. Thank you. So now for the next 15 minutes, I would like to invite Dr. Ghanshyam Vishwas, who's a consultant medical oncologist from Spurs Hospital, Bhubaneswar. He's a dear friend and senior, and he will be speaking on prevention and treatment of brain metastasis and leptomeningeal disease, especially in breast cancer. Most likely, he'll be speaking a lot of it on HER2 positive disease. Dr. Ghanshyam.
Good evening, friends, and thank you, TP, for this opportunity. So my role will be in the prevention and treatment of brain metastasis and leptomeningeal disease in breast cancer. So what are the challenges when you talk about breast cancer and brain metastasis? So incidence in a metastatic setting, highest in the TNBC, so around 50% patients, in HER2 positive, so 1/3 of the patients, and even in HR positive. So we come across few patients, so something around 14%. So blood-brain barrier efflux pump in the brain endothelium limits exposure to these cytotoxic agents. So in the yesteryear trials, you can see the patients with the CNS disease, so be it treated or active or a stable disease, were excluded. But so since the invent of HER2 agents, so now almost all the trials you can see, and all those anti-HER2 agents which are very active in the CNS, so most of these in the trials, so either an active or even a stable disease or a pre-treated brain metastasis had been included. So the breast cancer and a brain metastasis outcome by tumor biology, the subtype. On the left-hand side, if you see the CNS metastasis-free survival, so definitely it is better for those patients who are hormone positive. So be it a hormone positive with HER2 negative or a HER2 positive. And so definitely the worst is in the triple negative. So with a modest in the HER2 positive. So we can see the overall survival from diagnosis of CNS metastasis. So it looks that HER2 positive patients are doing good because today there are so many HER2 directed agents. So HER2 positive disease with or without a hormone positive, so they are doing good as compared to the only hormone positive or a triple negative. The current evidence. So current evidence on therapeutic approaches in the HER2 positive disease. So since we are talking about a HER2 positive disease, so now is there a role of a surgery or local radiation? Yes, there are patients. So who will, so how do you approach this patient? So first, if CNS is the only or the brain is the only or the first site of metastasis or recurrence, then try to get a biopsy done. You look at the discordant or the concordant of receptor status. Surgery to remove lesions causing intracranial raised intracranial pressure, especially for a solitary or very few ipsilateral lesions, gross total resections, and as I told, so I see biomarker and molecular profiling. So post-operative radiation to resection cavity, 50% recurrence rate in 1 to 2 years without a radiotherapy. So is it SRS versus WBRT after resection? So if the tumor size is less than 5 centimeter, a solitary has been resected out. So around 200 patients were, so where they are randomized between radiotherapy, that is SRS versus SBRT. So SRS 12 to 20 gray in 1 fraction, whereas in WBRT it can be 30 gray 20 fractions or 37.5 15 fractions. So now look at the cognitive deterioration. So we are concerned because there are few patients who will definitely have a prolonged survival. So there the cognitive deterioration becomes important. So SRS stands apart as compared to WBRT. But OS doesn't make much difference if you compare with an SRS versus WBRT. So what matters is the cognitive deterioration, which is much more with the whole brain RT. So what about 1 to 3? We know that beyond 3, so probably WBRT. So 1 to 3. So whether you are going to give SRS versus SRS plus WBRT, so you can see that SRS alone preferred for patients with 1 to 3 brain mets. Though the OS remains same, again the cognitive part actually takes over. So coming to systemic approaches in this group of patients who are HER2 positive. So in HER2 positive MBC, CNS disease remains an incurable despite current treatment options. So more than 50% of the patients with HER2 positive MBC will develop brain metastasis, and we know that trastuzumab and pertuzumab do not penetrate the CNS under the normal conditions. And so risk of CNS metastasis in HER2 positive MBC by be it ethnicity, race, age, performance status, hormone, so it doesn't matter because all these patients at some point of time, they will develop brain metastasis. The current landscape are small molecules TKI combinations, which can be a lap cap, we can say lapatinib and capecitabine, and then now the neratinib capecitabine, and after the HER2 climb study, so tucatinib, capecitabine, and trastuzumab. So all three together. Then we have an ADCs. So the widely getting used of TDM after the generic has been launched, and trastuzumab deruxtecan. So probably few of only of us has some experience. Otherwise, this is not available with us. So lapatinib and capecitabine, we can see. So the overall response rate with the single agent lapatinib has been less than 10%. The CNS overall response rate. If we talk about combination of lapatinib and capecitabine with the treatment naive patients, so 2/3 of your patients are going to have a CNS response. Even a pre-treated patients can have a 18 to 38% of response. So once we compare lapatinib capecitabine with a single agent. The cerebral study, which shows that CNS as a first relapse in HER2 positive MBC with lapatinib capecitabine versus trastuzumab capecitabine. So it was a negative trial, so nothing much was different. So the study was closed. Then came the role of neratinib. So on a phase 3 study, you can see neratinib and paclitaxel, so free of CNS progression, was much superior as compared to trastuzumab and paclitaxel. That shows that neratinib has a good CNS activity. On the other side, you can see combining neratinib with capecitabine, the waterfall. So you can CNS overall response rate is 49% for lapatinib naive patients. Even with the lapatinib exposed patients, so we can get a 33% of response. So with the neratinib and capecitabine. Then the NALA trial, everybody of us knows. So it compared neratinib and capecitabine versus the standard lapatinib and capecitabine. And so mind it, so asymptomatic stable brain mets were allowed, and the co-primary endpoints was OS and PFS. So we can see that the PFS difference was almost 2.2 months, and the OS difference was 1.7 months. So the NALA, the time to intervention, so you can see in the experimental group, almost 14 patients required intervention, whereas much more patients, almost 20 patients, required intervention in the lapatinib capecitabine arm. So tucatinib is a HER2 selective TKI with the good CNS penetration and has been shown active with TDM1, capecitabine, and trastuzumab. So in the phase 1b study, so these patients, pre-treated patients, or even treatment naive patients showed a good response, and that led to the HER2 climb study, so which was talked in the OSCO 2021. So addition of tucatinib to trastuzumab and capecitabine. So even in these brain mets were allowed. You can see in the primary PFS, so there was a significant difference of 7.8 versus 5.6 with a hazard ratio of 0.54. Even there was a significant OS benefit with tucatinib, trastuzumab, and capecitabine. So be it all patients with CNS PFS, again significant difference. Be it all patients in regards to OS, again favoring the triplet. If you see active brain disease mets with these triplet, there was significant probable CNS PFS benefit and OS, and this was not seen when only the stable brain metastasis was considered, though there was a PFS benefit, so OS were almost similar. So TDM1 activity, so there was no larger cohort, but again, so much reports were there that this drug is also active in the CNS with the overall response rate of 30% with a PFS of around 6 to 7 months. And that led to a phase 3 study of Camilla exploratory analysis. So in this, you can see after 126 patients with brain metastasis measurable, so overall response rate of 21% and clinical benefit rates of almost 43%. And these were patients without radiotherapy. So median PFS of less than 6 months, but almost median OS of 1.5 years. So the early clinical trials of TDM1 and HER2 in combination, so there are trials ongoing with tucatinib and TDM1, and also TDM1 with neratinib, so which are so actively ongoing accrual. So now another talked about is a phase 2 Destiny Breast 1 trial. So we are talking about trastuzumab deruxtecan. So we can see, so in 24 patients, overall response rate of almost 60%, even few patients went into CR. So that led to an approval, FDA approval of this drug in previously treated with 2 anti-HER2 in the metastatic setting. So HER2 positive leptomeningeal disease, again, is a bothering patient. So in our clinical practice. So 1 in 6 months or 1 in a year, you will see these patients. So nothing much. So intrathecal trastuzumab, I don't know how many of us have used. So 80 milligram can be used. So there is no dose limiting toxicity. So another one where so weekly twice of this dose, then you can use of weekly, and then you can put him on a maintenance dose. In this 26 patient, it showed that there are patients, after 26 patients, who had a good response, partial response is almost 20%, with a median PFS of 2.5 months. So the same triplet combination in leptomeningeal metastasis, that tucatinib, trastuzumab, capecitabine, is also showing some benefit at this moment, because we don't have much to offer in these situations. So the ASCO guidelines for managing HER2 positive metastatic brain metastasis, routine surveillance with imaging is not required if symptoms are not there. If symptoms are neurological, then probably you need to do an MRI and see. For patients whose systemic disease is not progressive, only brain metastasis, so you may not change the systemic therapy, but definitely if there is a systemic progression along with brain, so definitely your algorithm will change. So HER2 positive brain, the takeaways are, so there are empiric development of HER2 targeted therapies. We have talked about the TKI combinations and then the ADCs. However, there is more progress to be made. No regimen is curative. CNS overall response of 50% in the most successful studies. So come to HER2 negative. So HER2 negative, now there are so expanded options, armamentarium. On the HER2 positive, we have discussed. In the HER2 negative, so there is a cisplatin, etoposide, or combination, even at times high dose methotrexate. And if we talk about endocrine therapies, especially for those patients who are hormone positive, so we know that out of the 3 CDK4/6, so abemaciclib in the Monarch 1 had showed a CNS benefit, so that can be considered. And in the TNBCs, even so the drugs like capecitabine and the platinum, and especially we know that 20% of these patients will be a BRCA positive. So if there is a CNS metastasis, so out of the lot of PARP inhibitors, so talazoparib has shown a better response. So this is abemaciclib, median OS of 8.4 months. So there's evidence of deficient DNA repair in the breast cancer where there's a brain metastasis. So a BRCA deficient like signature is enriched in breast cancer brain metastasis and predicts a DNA damage. So breast cancer brain metastasis shows increased level of genomic aberrations based. And so this was, and with this, so BRCA was designed. So talazoparib, you can show as compared to standard chemotherapy with a BRCA positive disease had shown a significant PFS as compared to 5.7 versus 1.6. So even pembrolizumab has shown some responses with a median OS of 4 months. And so breast cancer clinical trials and brain the past versus the present. So past not so distant history of brain metastasis was a standard clinical trial exclusion, but presently, as I said, so most of these trials are including either active or pretreated or a stable brain metastasis. So these are some of the trials. So in the busy slide, so once a brain metastasis is diagnosed in a breast cancer patients, so select these patients who can be offered surgery, select the patients who can be a candidate of SRS or versus WBRT, and there will be a cohort of patients who may not benefit with any of the treatment. And so after the receptor studies, so then you can define, so if they are hormone positive, so whether your patient is endocrine sensitive or endocrine resistant. If HER2 positive, then first line, second line, third line, and beyond. And in TNBC also, so you can look at PDL positive versus PDL negative, so first line, second line, and beyond. So thank you so much for this opportunity. Over to Dr. Titi.
Thank you, Ghanshyam bhai. We'll just move on, and thank you first for sticking to time also. We now in the panel by Dr. Amit Ratan. He's head of department consulting medical oncology from Manipal Hospitals, Bangalore, and he'll be moderating a panel on practical issues managing CDK4/6 inhibitors. I'll take the opportunity to invite the panel, Dr. Shailesh Bondade from Nasik, Dr. Gautam Goyal, he's from Chandigarh, Max Superspecialty Hospital, Dr. Dodal Mandal from Max Super Specialty Saket, and we'll have Dr. Bharat Baswani again. I have requested him. Thanks, Bharat, for accepting it. I think Bharat Bhosle is sick and he would not be able to make it. Am I right, Tarun, or someone from the team? And may I have Amit? Dr. Amit is there?
Yeah. Thank
please.
you, Dr. Sahul. Thank you for inviting me. So this is what we'll do quickly in the next 24 minutes. Quickly discuss some practical issues in managing CDK4/6 inhibitors in advanced breast cancer. I'll stick to advanced breast cancer. There's enough to discuss in this talk.
Yeah, and one more thing before a disclaimer. We wanted to do this because this was nothing to do with pharma. Always when CDK4/6 come, there's a session which is sponsored by pharma. So there are compulsions for the speakers. So I think Amit is going to do a good job on this.
Okay, so let's get started. We have discussed this n number of times. In every talk, we have been talking about these first-line trials, 4 first-line trials, hazards exactly 0.55, doubling of PFS, and all of us were till now convinced that it will give us OS benefit. And this ASCO's data. It has come as a surprise. So last year we saw the Mona Lisa 2 ribociclib getting 1 year survival advantage over letrozole alone. And Mona Lisa 7 we had already seen a couple of years ago with the OS benefit. And this year the Paloma 2 palbociclib data was presented in ASCO 2022. And it was a surprise, 51 months versus 53 months, hazards exactly same. And no statistical significance with addition of palbociclib to first line. And this is really created a lot of furore and talks. So I wanted to bring this up first. That's the elephant in the room. How do you choose first line data? Will overall survival data matter? Dr. Sailesh, let's start off with you.
Yes, I would say that the overall survival does matter, but also the toxicity and the quality of life on treatment also will matter.
Okay. And do you think this Paloma data which came in, how are you thinking about it now in first line setting? It's too early, but we start thinking now.
Yeah, I mean, at least with the data, I'm more inclined towards using ribociclib.
Okay, so the thought is going that ribo has the OS advantage, which this doesn't have. Okay, right. Dr. Gautam, your thoughts on this OS data about Paloma and about ribo, is it inclining you in one way or the other?
So I was a bit astonished. I didn't know the data, but that is a bit astonishing that there is a no OS benefit with use of palbociclib. I consider all the 3 drugs as a similar group of drugs. So it is very astonishing that one group of drug is not showing any OS benefit and the another group of drug is showing a very good significant OS benefit. I have been already inclined toward using palbociclib plus letrozole as a first line because it has been used too often as compared to the other 2 by myself. So, but I will have to think over using it now from the next patient onwards.
Okay. So it is making you get up and think what. So it's a very surprising data. Dr. Mandal, what are your thoughts on this?
So I must agree that I am the odd man out in this medical oncology community using all these CDK4/6 inhibitors. But yes, I think to me also the toxicity and quality of life will also matter, because if I have to choose between 2 drugs having similar efficacy, I'd go with the one with better quality of life and lesser toxicity. At the same time, I'd also keep in mind that few of these patients might require radiation during their course of treatment. So of course, a drug which will have less toxicity when we combine radiation with them, I'd prefer that one.
Okay. Can I chip in, Amit?
Yes.
Yeah, I mean, I agree with whatever is said. You know, it's surprising that with the same HR and same PFS with all the 3 drugs, one study shows that the OS is better. But you know, in a metastatic setting, it matters a lot to what patient takes after the progression, and that might change the course of and the OS in these patients. So it may not be 100% good to judge on the OS only, because it does matter that what the patient could take after the patient has progressed on the first line.
Yes, so there's been a lot of talk on that in the ASCO analysis by Dr. Finn. He looked at a lot of aspects, but very surprisingly, the explanation they were giving is we don't have enough. There were a lot of dropouts in their follow-ups.
21%.
That was the issue. That's what they were talking about. Bharat, what do you thought? Why do you think this?
Sir, the thing is, we need to now realize the discussion that Palbo among the three is the least potent drug. Sir, since the discussion is purely academic, it failed in adjuvant, Palas failed. It failed in second line, Paloma 3 failed. So there is no surprise for us that Paloma 2 should also fail. So that is something that we have realized initially. The advantage with Palbo was that it came early. So most of us invariably use and the PFS was better. Now we have already realized for other two drugs that, sir, the OS already, this is just an endorsement that probably the three drugs are different. And now it is a high time that we should sit down and choose a drug for the situation. Probably we had a good data in primary endocrine resistance with one of the drugs, not for the other two things. So for me, yes, sir, I have to be very clear that this is a time when you have a data, you have to accept that data. And when one data says that there is an improvement 53 versus 51, even if you remove that 21% patient, it is only 7 months. It is 53 versus 45 to 46. Then they try to go into that subset, DFI more than 1 year, bone only, performance. But I think so, sir, we should now start accepting. Otherwise, there is no point in discussing. The discussion is all about the data.
Another thing, another thing, Amit, I think is, if I'm not mistaken, I'm not very sure, but with palbociclib, I think they had taken patients with a poor prognostic factors also, and those who has progressed within 12 months of completion also. Whereas in the other studies, they were playing very safe and they took all the patients who had progressed after 12 months of completion. That also could matter, I think.
Yeah, that could also play a role. But the PFS is exactly the same. So that's why you kind of get you still think this OS data could be something related to the patient population, because otherwise the PFS would have been different. Right, Bharat, you were saying something.
Sir, Shailesh sir exactly put up that point. But again, sir, that was not a pre-specified DFI more than 12 months. It was 65 months in this data, which is probably again as good as the other two. But sir, this was all again an analysis which was done as per the forest plot. So probably not that much significant. At the end of the day, the most important thing is what is the overall outcome, sir. But if we keep on getting both in between whatever, but then that doesn't help us, sir. In
so it is a tough decision now. Sahu, you sort it out for us.
No, it's difficult. So, but one thing is, I still believe there's something left. We just cannot let go Palbo so easily. I strongly believe the full text has to be read, and there would be reason for it, because you get the responses the same across the three drug in first line. You get the PFS sitting on the same thing, the hazards on the same thing of PFS, and just the survival just getting haywire. I feel something is missing, and we are missing something in this data. I totally accept, Bharat, that Palbo has been failing in all aspects. First line, second line, adjuvant, everything has been a negative thing for them as per the data. But I would still not let go of Palbo so easily. We have had our long-term survivors. It is very easy to manage. It's okay that it was a first comer. The advantage is there. But we have been talking in the metastatic setting, the PFS is the way we talk of a lot of other things. The PFS is exactly the same. I would like to read into this. I would not draw my conclusions based on the ASCO presentations.
Right. So okay. I think I would.
Can I ask you, what are you going to do?
No, I agree with you, and I was going to endorse what you said, because I would say for us, Palbo has been time tested. We have been through it for so many years now. We have got familiar with it. But the difficulty will happen is when you get OS data, if your patient asks you, will I get an OS benefit? We have to justify that. So that's the whole decision, and it's going to be, I think it'll take us some months to really analyze this data, understand it much better, and then see how we are going to interpret it for our patients. But I think it has created a lot of talk, a lot of dilemma into practice, and I'm sure we'll be hearing a lot about it now. So moving on. Okay. Hormonal backbone first line therapy. Gautam, to you, does it really matter? Would you use fulvestrant for any patient, or are you happy with AIs in first line setting? This is what we normally always talk about sometimes.
You need to unmute.
Unmute Gautam, sir.
So, as per the patient preference, or you can say ease to administer, I prefer AI in the first line. But as the data of ribociclib and fulvestrant came, and which showed that there is a significant benefit, I do consult them now for that. Fulvestrant will be a better option as compared to AIs. But having said so, most of my patients start with AI plus CDK as compared to fulvestrant plus CDK.
Right. I think AI CDK4/6 is much more simpler, straightforward for an untested for a patient who has not received any treatment, and we have the Parsifal data using first-line fulvestrant versus AI with palbociclib, and clearly there was no change in the PFS at all. Both the curves are right on top of each other, which really answered our question. We would prefer it, but there was this interesting study last time where you looked at patients who got AI palbociclib, and then you did cell-free tumor DNA at regular intervals. And if you found out that you developed an ESR1 mutation, then you changed to fulvestrant. And that was a very interesting study. And I think that will be the way forward when we talk about personalized medicine. Though I know we are nowhere there. But it was good to see that there were some people looking at this in this aspect and trying to treat patients in this way. So it was a pretty good, interesting study to read.
Can I speak can I pick up one question on this part? Is how practical is it, because the PFS in the Parsifal, if not result 27 or 28 months, and if you're looking at that PFS beyond 2 years, and you ask a lady to go for an injection once every month, one in each buttocks, and then versus a tablet, who's going to go for an injection? That's a question that has bothered me.
I agree with you, Sahu, but tell me, if this same lady came to you with a ESR1 report saying ESR1 mutation present, would you not answer?
Agreed. And if you look at the ESR1 story and the PADA, if the trial what you're speaking of with the regular thing, it's difficult to do it in practice. You are not going to do a mutation analysis every 2 months or 1 month. But my point is, the ESR1 mutation is much more common after the first 6 months. Within the first 6 months of relapse with the hormone therapy, the ESR1 mutations is very low, to the tune of 10%. Then the ESR1 mutation actually picks up beyond 6 months. So if the mutation is there on my table, all of us would go for something of a fulvestrant type. That's the best we have at this point. But a baseline ESR1 mutation, others can correct me, is not great. It's a single digits or maybe lesser.
2%.
That's what my take is.
Yes. No, I agreed fully. I think all of us have fully AI fans, and AI CDK4/6 was the way forward for all of us. And this Parsifal actually just told us that, yes, we are doing correct and we don't really need to push anyone to fulvestrant. And
to actually come over this, I think there are a lot of trials going on with oral SERDs along with palbociclib. So that might answer our injectable issues.
Absolutely. And now these SERDs will come and create so much confusion. Already the 3 ones all the 3 trials are different. And now again, they have created confusion, 1 positive, 2 negative, and already debates have started. So I think it's going to be a very interesting field for us. Endocrine therapy versus chemo. Dr. Sailesh, any thoughts on that?
I think we always used to think, that in crisis, chemotherapy is always first as compared to the endocrine therapy in the metastatic breast cancer. But I think there is a lot of data that to say that it is not that bad, to start with the CDK4/6 and AI. And not always rely on chemotherapy as a first line. But there can be some situations, specifically when you have a lot of pleural effusion and things like that, where you need a rapid reduction in the tumor load. You might go for chemotherapy. But I think we are now becoming more bold to use a CDK4/6 and a combination of AI or fulvestrant, depending on the situation, in the first line instead of chemotherapy to start with. I think we are understanding and we are becoming more bold.
Absolutely. Fully agreed to that thought. We are all becoming more bold. I think that's the correct word, and we are seeing those results also, and that's why we are getting more and more encouraged. So I think all of us would kind of endorse that thought. I was a little bit. We've been seeing this data for 2 years or so. Last time, the young Pearl data and the Pearl data, which actually helps us tell that chemo is better than endocrine, at least in the young Pearl data. I mean, endocrine is better than chemo in the young Pearl data. But my thought was, I don't know how they did this study, because it is so difficult to choose patients with non-visceral mets and still look at a study and do it in the present setting, trying to give chemo upfront. Yes, Bharat, you were saying something.
Sir, Pearl basically was not a good, because it has the subset, if you to see, it was primary endocrine resistant. They had an early relapse patient on the AI they have taken, and we all know that Palbo never works in a primary endocrine resistance. So Pearl probably just fulvestrant, well, Palbo was not the right partner, because the subset of patient was not the patient where Palbo really works. Now the right study was a young Pearl study, and probably that gave that the endocrine subset with a CDK4/6 was better, 20 versus 14 months.
Yes, absolutely. But I feel the young Pearl is a very difficult study to do.
Yes, very.
But it proves a point. It is good to talk about saying that it is really non-effective. Okay, Dr. Mandal, any role of biomarkers? And another specific thought was, if you see a PIK3 mutation upfront, what do you do? What are your thoughts about this same approach? And what do you think your patients will behave well or bad?
I'm very sorry. I just pass on this question to a medical oncologist for a better response.
Absolutely.
Because I really do not practice systemic therapy.
Right.
Okay. Yeah, as for me, I'll take the second one first. If I have a PIK3 mutation, will I do anything different? I don't think so. I have data from the landmark trial for the PIK3 inhibitors that a prior use of CDK4/6 does not in any way alter the way how the PIK3 mutation acts in the second line. So I would not do any role of biomarkers. The only thing which I'm feeling is the ESR1 mutation story is something that might change how we're looking into it. But lucky for it, that early on it is very, very low. So at this point, I would not be doing any other biomarkers. Others can come in. That's what my thought was.
TP, do you think that the PIK3 CA mutations, if they are present in the beginning, the PFS is worse than that of those who don't have?
Okay, the PFS, if it is a PIK3 positive, I don't think there is any large trial to show us that. I'm not aware of it. I don't think so. Bharat or maybe Amit can take it further.
So the Mona Lisa 2 subset, you can look at it. They had PIK3 there right in the last one, and they saw PIK3 wild type and PIK3 altered exactly the same benefit.
Yeah.
So clearly, what you're saying is perfectly correct. It does not matter. The benefit is exactly the same. Though we have seen publications from various centers, and actually there was even, I think the last ASCO there was an Indian small study from if I remember right, from Kerala, which actually looked at a retrospective analysis saying their PIK3 mutant patients upfront with Palbo did not do so well. I did read an abstract like that in ASCO or something. But our the phase 3 trials have clearly said it does not matter. PIK3 positive or negative, we still go the same way and they benefit the same way. The biomarker analysis story is really good, and it does not.
Just to add one thing to what Dr. Bondade told, the PIK3 itself gives a poor prognostic criteria. The Bolero 2, there was a subset analysis which told that the patients who were mutated did the worst, even if with the everolimus combination with XC or exemestane. So that is there. They do worse, but yes, Amit, that's what we spoke, that per se you would not change therapy because there's a PIK3 based.
Yeah. Right. And the response to CDK4/6 is the same, whether you had it. Right. I was a little surprised at this data where maybe the RB loss did not show any difference, but I think the confidence intervals are very wide, because I would think if there's an RB loss, then obviously a CDK4 will not work. But again, these numbers are very small. You hardly see RB losses. I don't think it's just that we talk about it for resistance, but we hardly see it in practice. So eventually the bottom line is only ER positivity is the only biomarker, and every ER positive you would treat with this combination, and that's absolutely the way forward. Gautam, what do you do for ER low positives, ERPR low positives? Do you still convince this way, or those are the ones you tilt towards chemo a little bit?
So if it is low ERPR positive, yeah. If it is low ERPR positive, I do look at the visceral crisis. If there is visceral crisis, I am inclined toward using the chemotherapy. But if there are no visceral crises, so CDK4 inhibitors plus hormonal therapy is my choice.
Absolutely. I think that's the way all of us think about, and we say we'll give them a benefit of doubt. So the other thing was CDK4/6 after progression. Bharat, what do you do?
Sir, if you would have asked me 10 days back, I would have said maybe no. But I'm a big yes now with the data of maintain that has come with a PFS nearly twice. When you continued, when you changed Palbo to Ribo and probably exemestane or a fulvestrant, I think so for the first time we have a good data. We were waiting for, there were 3 studies, maintain, PACE and Trinity. So PACE was a negative thing. Maintain is a big yes now. So for me, sir, actually, if you ask me, we were doing it, but we were continuing the same agent and we were changing the endocrine partner. Maybe because that was what it was available. But this trial has clearly shown that PFS of around 5.75 versus 2.5. And that has also shown that you should start looking at ESR1 also. Because, and if you have a ESR1 positive, this was a bit of a surprise that you should not use a fulvestrant. You should use a exemestane. That was the other way that confused me, but that is what the trial suggested. So for me, I will continue CDK4/6 beyond progression, but I will change the partner, probably if it is Palbo to Ribo. That is as per the data of maintain.
So that's what this maintain was very intriguing. So for everyone, and again, this point will come up for all our practice purposes. So all of us were doing it because sometimes we had the free drug and our patient progressed a little bit. We don't want to stop the free drug. And we used to just change the hormonal and continue it. But are you, I see the benefit, but are you impressed with the numbers? The PFS for 2.76 versus 5.29 months, not that great numbers. So that's what makes me think, should we really go by this, or should we really switch everything as what we used to do earlier? Shailesh, what are your thoughts on this?
The arm is very poor.
I think that the comparative arm is a strong arm versus a weak arm.
Yes, sir. Agree.
So you are not inclined if you would continue?
Yeah, no, I'm not very impressed with the PFS difference, though it may be statistically significant.
Right. So yeah, that's the main thing everyone's talking about. There's doubling of PFS, but the numbers are really small.
Yeah.
And maybe because it's such a small number, you're not able to get a proper interpretation out of it. And even the ESR data out of this was very, very uninterpretable. It was very, very difficult to understand it also. But I think the PACE still not yet come out. The PACE has to come out. The further data from PACE is to come out, and probably that will answer better. I think it has bigger numbers compared to this.
Just a pointer. I don't have data for that. I don't have evidence for that. But I feel if I have to change over the CDK4/6, I would go to something more probably of a continuous pattern like Abima. Because that looked different to us earlier. Am I impressed with the data? No. Will I do this? If in a frail old patient, I just want to carry on with the hormone therapy, probably that's when. Also, it's very interesting. It will be very interesting to look into where the patient progressed and how were the progressions, whether it's oligo progression or were the massive progressions. And did this PFS turn into OS data also? I think there are a few questions which are unanswered. It is intriguing, but is it practice changing? No. Will people do it? Yes. That's a very clear answer. When it's to our convenience, we try to do it.
Sir, I just want to put one more point. Sir, if you see the Flatiron data of a real life practice, the subset which had the maximum OS was those who continued CDK4/6 beyond progression. So if somebody has time, go through the Flatiron data of CDK. The subset which are best overall survival was where CDK, although that was not a trial, so we can't quote it. But again, an academic forum where we can think of it because real life has data to suggest that it works.
And I would say, sort of again, agree with Sahu. They're saying that sometimes it's oligo progression. So there we really don't bother too much. We just continue the CDK4/6. Yeah. But if there is an obvious multi-system progression happening, I think it's time to change. I don't think we should really continue the...
Sir, I will have a point. As with Dr. Shailesh, if there is a multiple site progression, so the next line would have been a endocrine therapy plus maybe everolimus after CDK progression. So in this trial, if it would have been better, if it would have been tested Ribo plus ET versus maybe everolimus plus endocrine therapy.
Right. I agreed fully. It was an inferior arm as per what Dr. Shailesh also was saying. So that's probably a part. And I think we will see some more data coming out of it. I wouldn't be surprised if the OS does not change actually. It may be just the same. That's what my thought is when it comes out. So let's see how it is, but I agree with you. Toxicity experiences. This is your real life experiences and dose reductions in each group. How bad is it? How good is it? Let's start off, Sailesh, your thoughts in practice.
Fortunately, I had experience of all the three CDK4/6, and I feel personally that palbociclib is a little better to handle as compared to the other two drugs, and probably has only one type of toxicity, that is the marrow suppression, as compared to the other two drugs. Though even though it's said that abemaciclib you can give continuously because the type of you don't expect so much of myelosuppression, but in practice I have come across a febrile neutropenic patient as well on abemaciclib. So I practically feel we are maybe because we are using it for a long time more comfortable with palbociclib as compared to the other two.
Right. Even we feel that palbo is the easiest to tolerate, and the other two are learning. Bharat, your experiences?
Depends upon where we are. In the first line, I think so. Probably I have not encountered with the quite a number of patients that we have seen. For my experience has been good with all the three, sir. So discontinuation less than 5%, dose reduction 1 in 5%. I can always think of it. So, sir, probably in a later lines of treatment, maybe when we have used quite a few chemo and maybe then we have tried, then this toxicity is quite high. In a newly de novo patients or probably in a second line, I think so the tolerance is quite good. And now with the increased use, I think so more or less we are comfortable with all the three now.
Agreed. I think all three are very comfortable.
I have a different point of view.
Yes.
I understand that if you go by the toxicity grades, the toxicity may not be so much, but that continuous marrow suppression, continuous mild anemia, fatigue, weakness, this is very common with palbociclib. So in my practice, 1 in 5 patients, I do decrease the dose in palbociclib, not because of that there is a grade 3 or grade 4 toxicity, but because of that there is a persistent low grade toxicity which is hampering with the daily activity of the patient. So means daily activity of the patient, that patient complains of that there is a continuous weakness. I feel fatigue. So that I will say that there is to me, it looks that there is a significant amount of toxicity with these drugs.
Okay, so that's a different experience. But on the whole, all of us are very comfortable with all the group of drugs. Those reductions are very minimal. Whatever said on them, they are very minimal, and most patients do quite well in the long run. So I think we're coming to the end. We are running short of time, so let's quickly premenopausal patients. Sahu, you have a preference for premenopausal? Which one, or are you comfortable with all?
First comer first. So ribo takes the cake. So I have had patients comfortable with it, and I do it. I don't get a lot of premenopausal who are eligible for this drug many times, but yes, of the few I've done, all have been riboside.
Okay, so you are ribo. Gautam?
So I do prefer ribo, but yes, we can do all the three because actually we are converting the premenopausal to postmenopausal by using the GnRH agonist. So if I'm not using tamoxifen, I'm using GnRH agonist, all of the three drugs can be used.
So, and the data is so as it is that first come first serve, and they did a big trial, so that's why ribo gets a preference. But clearly, you've seen the data sets from all of them. The benefit is exactly the same, and all the data sets have patients of premenopausal. So as shown here. So I think we are comfortable with everyone. So last question, brain mets, Sailesh, what do you do?
Abema would be the first option as compared to the others.
Okay, yeah, Bharat, yours?
Yes, sir. Abema. This is something where this is the main advantage of giving Abema, that it has maybe a better CNS penetration, although other data, ribo also have real life data now. But sir, I'll prefer Abema. With brain mets, definitely yes. Abema.
If you had asked me 1 year before, I would have gone with what both of us were telling. But I presume that the data was from a very small subset of Abema patients. All I feel is all of us do treat the radiotherapy. And after that, I think you can take for any drug. That small data of few patients is for Abema. I don't think that you can just take it as Abema, not the osimertinib type of thing for lung cancer. If there's a CNS, I'll go for osimertinib. So that's my take on it. I'm gradually changing my thought on that.
So if you have a patient with asymptomatic, very minute, multiple CNS mets, maybe 3 or 4 or more, but patient is asymptomatic and there is no peripheral edema to the mets, will you be giving radiotherapy or will you start with Abima only?
Sahu?
It's to me, yeah. What do I do practically? If I have a patient who is in the city, knowledgeable, well-educated, understand what I'm speaking, I'll put the patient not on radiotherapy. But if someone who are not very comfortable, uneducated, or far away, I do radiotherapy. I know there is not data for that, but I do it because one conversion, and I know that I lose the patient.
So, but in this type of patient where you are giving radiotherapy, a lot of patient will have a derangement in the brain functions down the lane after 6 to 12 months. So is there...
Thought is do always SRT as much as you can. Don't avoid whole brain radiation.
SRT is available. Even in Chandigarh, it is available at one center only. So SRT is not a very, means from A cities, B cities, no, SRT is not available.
I think you can I'm just interrupting. So you can think about using concurrent memantine in these situations, which can prevent loss of memory significantly. So there is a specific trial for this when you use whole brain radiation with or without memantine. Patients getting whole brain radiation along with memantine during radiation and 6 months post radiation, they have significantly better memory and neurocognition.
Dr. Mandal, can you share the this reference? This is news to me. Can you share this on this chat?
About it, but just tell us about it a little detail. How do you do and what do you do?
And Amit, it will be last question.
Yes, this is the last question. Finished. Dr. Mandal, last.
Yeah, so if I know that the patient is going to receive CDK4/6 inhibitors, then at least I would prefer giving radiation before starting it. And at least I would like to wait for another 2 weeks before the patient is put on CDK4/6 inhibitors, because there are some anecdotal reports of radiation recall phenomenon after starting patients on CDK4/6 inhibitors after radiation. So depending on exactly which part of brain is involved, if it is a very eloquent location like brainstem or some specific area having significant neurological function, then probably I'll not be very keen to start radiation because they can have significant radiation recall phenomenon. Otherwise, I'll be happy to start radiation, wait for 2 weeks, and then request our medical oncologist to start the CDK4/6 inhibitors.
Dr. Mandal, the data on memantine, what do you do? How do you do it?
Oh, so when we start whole brain radiation, you can actually try to spare the neurocognition, prevent the neurocognition loss and loss of memory by 2 methods. One is by sparing the hippocampus. Of course, it needs a very dedicated MRI and dedicated CT sequence during radiation planning. And we need to delineate the hippocampus and then give a specific dose constant so that the dose within hippocampus does not go beyond the limit. And this technique can be employed for patients who do not have any metastasis in the immediate vicinity of the hippocampus. Now, this can also be added.
Dr. Mandal, I need to pitch in. Can you finish in 10-15 seconds?
Yeah, so you can add memantine at a small dose like 5 milligram twice daily from day 1 of radiation, gradually increasing it to 20 milligram daily, and then continue for 6 months after ending radiation.
Okay.
Yeah,
right.
so I'm just sharing the link of the study as well in the.
Yeah, please do that, and that will be great. Yeah.
Thank you very much. So thank you, everyone. Excellent discussion, and thank you, Sahu, again. Thank you.
Yeah, thank you, Amit, for taking this up, and thank you, panelists. And I think we should have more of this non-pharma discussion, and it really brings out a lot of intricacies into this debate.
Thank you so much. Thank you.
Yeah. So let's go on and move on. And now we're having another very beautiful topic. It's a fertility preservation in young early breast cancer patients. It's something that we need to discuss furthermore, especially in tier 2 cities. I know that people in metro are doing it much more. Also, we have Dr. Minu Walia, who is the Senior Director, the Department of Medical Oncology, Max Office, Specialty, Delhi. Madam, just one request, 15 minutes, madam.
Thank you, Dr. Sahu, for the opportunity. And definitely, I will try to stick to the time only.
Thank you, madam.
A very important topic, I think, in today's date, fertility preservation in young early breast cancer patients. So let's have a look at the stats. Are these a big chunk of patients, or we are talking of a minuscule of our patients? Then the answer is it is a considerable number of patients. The stat says that 20% of breast cancer patients in America itself is less than the age of 49. Almost 12,000 of women every year belongs to this category, and 7% are generally less than 40 years also. So for this subgroup of patients, yes, fertility preservation is very, very important. And as we know that in our country, we seem to be seeing a lot of breast cancer patients in much younger age group than the Western population also. And chemotherapy invariably is a very important component of treatment of this subgroup of patients, and the detrimental impact of cancer on ovaries and on fertility can be quite severe. And as we talk about cancer survivorship, a very important parameter of cancer survivorship and quality of life is the lady being able to have children, the capacity to have children later on in their life. So, and with the rising trend in delaying childbearing, we do expect that with the coming time, the demand for fertility preservation is going to further increase. Contrary to the male counterpart, a female is born with a definite number of eggs, definite number of oocytes, that is approximately 1 to 2 million oocytes at birth, and that is all that she has, and that is at the time of birth only. And over a period of time, we know that her capacity, she loses these oocytes, and her capacity to bear children will further decrease. And this capacity to bear children is greatly compromised with the cancer therapy in whatever form we do, whether it is chemotherapy or radiation affecting the pelvis. So, which accelerates this deficiency, which accelerates this process, and further compromise happens in the decline in the oocytes that happen. So, what do the guidelines say? Should fertility preservation be an important part of the discussion? Then we know that in today's date, the guidelines say that it should be actually be a part of the informed consent to cancer therapy. So as important as whenever we are discussing the side effects of chemotherapy, we are discussing the pros and cons of treatment, the discussion about fertility preservation should also be a part of the informed consent. So if we all agree to, yes, it is an important part of discussion, whether discussion should be done or not, then if it has to be discussed, then what is the right time to discuss? Then the right time is as soon as possible, because we know that it has to be done earlier in the treatment planning, as early as we plan treatment, and it should be done before initiating the gonadotoxic therapy. And in some cases, it can actually delay the start of therapy, so it should be done as early as possible. Then who should be the right person to do this discussion? Then the answer we all know is the infertility specialist. But yes, we do also understand that not everybody is fortunate enough to have an infertility specialist at the place where they work. And then possibly the onus of discussion then comes to the oncologist, whosoever treating the patient. But we all know the data says that there are a lot of challenges for the oncologist, and in practice, this discussion happens only for a minuscule of the patient. Even in countries like US, the data says that the fertility discussion happened for only 35% of the patients who should have had the fertility discussion. So we know what are the challenges. The challenge can be in the priority, in our prioritization. For we as oncologists, yes, cancer treatment is always a priority compared to these quality parameters. Second is, even if the attitude is there and we understand the importance of discussion regarding fertility, sometimes we lack the resources to facilitate this discussion. And if at all we do not lack the resources also, if we do facilitate the discussion, the biggest dilemma is where to refer. As Dr. Sahu very rightly pointed out, we are fortunate in the metros that we do have infertility specialists, we have access, we have the infrastructure, but not everybody may be fortunate enough. And in a smaller town, this may itself become a big problem. So in today's date, the the onco fertility by itself has become a branch in itself, and so much is the importance that is being given all over the Western world, and now seemingly it will seep in our country also. So what are the factors that need to be considered during onco-fertility counseling at the time of diagnosis? Of course, as oncologists, we cannot by look, or down look about the cancer, the type of cancer, the stage of cancer, the urgency of treatment, the type of treatment plan that we are going to give. Everything is important. Apart from that, the age of the patient, whether the partner is present or not, the other medical history, whether the lady already has some ovarian reserve, so which can easily be assessed with the markers, and if at all she has had any previous gonadotoxic therapy or any previous treatment for infertility, all these things. And also a very, very important point, whether she has some hereditary conditions, inherited disorders, that needs to be taken into account at the time of this discussion for oncofertility. So diagnosis of cancer, as soon as the treatment plan is made, one has to assess fertility risk based on the treatment plan. And if at all there is a fertility risk based on whatever chemotherapies that we are going to offer or anything else, then if the answer is yes, then the patient needs to be informed about the fertility risk. In case if we are not sure, even then the person needs to be informed about the fertility risk. And what is important is not only informing, not only documenting that we have informed about the risk of infertility to these patients. What is also important is documentation of this discussion, that this was discussed with the patient and these were the things that were discussed with the patient and what was offered to the patient. So this we have now incorporated in our consent forms itself, that we do discuss with majority of our patients and we do document this discussion. And if the patient wants to go for fertility preservation, then the next step definitely comes, the referral to the right fertility preservation specialist. Coming to chemotherapy, we know that majority of the agents that we frequently use in breast cancer have a high risk of amenorrhea and cause direct damage to the oocyte. So our anthracyclines, cyclophosphamide are known to be highly toxic, including cisplatin. Taxanes itself, although the risk is not clearly known, is considered to be intermediate risk. And various other, these are the common agents that we use in our breast cancer patients, which are known to impact the fertility potential of the lady. So how does chemotherapy affect the ovaries? It causes destruction of the growing follicles. Not only the growing follicles, because the growing follicles are destroyed, there are more of primordial follicles which will be recruited and they will also be in the process destroyed by the chemotherapy, leading to an overall loss of ovarian reserve, ovarian atrophy and ovarian function failure. So this is just a schematic description of the same. So not only the chemotherapeutic agents destroy or kill the growing follicles, but they also cause recruitment of further primordial follicles and ultimately cause destruction of the primordial follicles and cause direct damage both to the oocyte as well as the supporting cells and leading to oocyte death. So what are the important points that need to be taken into consideration in a lady who is an early breast cancer patient and for which fertility preservation might be important? One is very important point is, can chemotherapy be delayed by 2 to 3 weeks in a patient? That is something which we need to understand. If it cannot be, then probably our approach to fertility preservation will be very much different. And if at all we can delay, which can very well happen if a patient is undergoing surgery upfront and we know that there will be a gap of 2 to 3 weeks before chemo is to be initiated, if that discussion is started at that point of time, then we further need to see whether whenever we are doing this fertility preservation, does the lady also has an estrogen dependent malignancy, and the so-called possible risk in increasing the estrogenic stimulation needs to be countered too. So going further, what are the methods? How do we do? What are the methods that we offer to all this subgroup of patients for fertility preservation? The gold standard all these years have been the embryo cryopreservation, provided the partner is known. The partner is already there, and yes, the easiest and the best method is embryo cryopreservation. If there is no partner, then the next best is oocyte cryopreservation. If nothing can be done, then there is something called as ovarian tissue cryopreservation also, although still not taken as a standard, still considered experimental by various agencies. And next comes, which I feel nowadays we all medical oncologists have started incorporating in our practice also, ovarian suppression with GnRH agonists. And then last but not the least, even oocyte donation and gestational surrogacy always remain an option for this group of patients. So just a schematic description of cryopreservation. Initially, we need to give gonadotropin, that is the oocyte stimulation. Once the ovaries are stimulated, then under ultrasound guidance, the oocyte are aspirated and harvested. If the partner is there, embryo, the fertilization happens in vitro, and embryo cryopreservation, embryo can then be cryopreserved, and this is something which has got maximum success rate compared with all other methods. So embryo can be created in vitro. 10 to 14 days is an average which time which one has to wait before starting chemotherapy in this subgroup of patient. Oocytes are harvested under ultrasound guidance. Sperm from woman's partner can be used to have the embryo created in vitro. The risk, a very important concern that we all oncologists are generally bothered about, is the induction of high estrogen level during ovarian stimulation. This can be mitigated to some extent by aromatase inhibitors. So this is what is time tested and something which is recommended by all the agencies and is the preferred method for fertility preservation in patients undergoing chemotherapy. In case the partner is not there, then the other best known method is oocyte cryopreservation. Again, a time lag of approximately 10 to 14 days from the beginning of the menstrual cycle. Oocytes will again be harvested, and again our concern is high estrogen level. During ovarian stimulation, and aromatase inhibitors can be used to mitigate the effect. Ovarian cryopreservation still considered experimental by various agencies. In our country also, we do not yet have approvals for this. However, it can be the last resort. As how it is done, the strips of ovarian tissue can be easily obtained by an outpatient surgical procedure, frozen and reimplanted when pregnancy is desired. However, a very, very important concern is if the lady is at risk of developing ovarian cancer, which is a known risk in many breast cancer patients, then probably ovarian transplantation is something that might be a big question mark. So the most easily done but not proven to be that efficacious is GnRH agonists. We know that once cytotoxic chemotherapy is being given, there is oocyte toxicity leading to decreased estrogen levels and increased FSH levels, which further leads to follicular recruitment, further damage to the ovaries, and further ovarian atrophy. And how can we block this? We can block it by giving gonadotropin agonists, and the sustained level of GnRH agonists rather than pulsatile levels will kill the cycle at this level, and possibly it will cause the ovaries to be quiescent and probably decrease further follicular recruitment and decrease the damage to the oocytes. And what is the best time if we want to start our patients on GnRH agonists? The best time is to administer before starting with chemotherapy. How much time before? At least 1 week prior to starting chemotherapy, and then to continue concurrent with chemotherapy to protect ovarian tissue. What is the effect? We know that there are studies that show that if these agonists are co-administered along with chemotherapy, there is a higher rate of resumption of menses after chemotherapy, higher rate of preservation of ovarian function, and also successful pregnancies do have happened in these studies following chemotherapy with GnRH agonists. However, till date, there is no randomized trial to this effect, and we have multiple studies, and the studies from the data are not very conclusive. So, what is the take home? GnRH agonists, yes, a big yes. As far as resumption of menstrual cycle is concerned, as far as preservation of ovarian function is concerned. However, if we take it as a substitute for fertility preservation, then the answer is no, because for fertility preservation, the first choice still remains either embryo cryopreservation or oocyte cryopreservation. This may help, but still we do not have a standard randomized phase 3 trial. A very, very important point is whenever we do talk about these things in a BRCA mutated breast cancer patient, because they
Madam,
are
a minute, ma'am. 1 minute more.
I'm just finishing. So in this population, there are two important things. One is we are going to offer them risk-reducing salpingo-oophorectomy in the near future. And also we are concerned about passing this mutation to the offspring. And all the more reason that fertility preservation needs to be discussed with them, because we want to do prophylactic bilateral salpingo-oophorectomy very soon, and pre-implantation genetic diagnosis PGD testing should be done in this embryo, so that to mitigate the risk of BRCA transmission of BRCA mutation to the offspring. So, do pregnancies happen after cancer? Yes, but most of the times we ask a patient to wait for 2 years. Does pregnancy increases the risk of cancer? Not known to increase the risk of recurrence or risk to the offspring unless the chemotherapy is given during the gestational period. Most survivors of cancer and even the offsprings of these cancer patients do not report increased cancer risk or unless it is a heritable cancer. So this is my last slide. What are the take-home messages? Cancer survivorship rates are high, especially the breast cancer. And that is why fertility is an important aspect of quality of life and needs to be discussed with each and every patient where fertility preservation may be decided, and not only discussed, it should be documented also. It should be part of the informed consent, and we should be aware of the various methods, and wherever possible, we should try to refer these patients to the fertility specialist also. Thank you.
Thank you, madam. And that was really a good talk. And we all should be putting a lot of time into all the counseling these patients for the preservation of fertility. And that's a big issue. Once the cancer gets cured, you are stuck and the ladies are stuck with these issues, and that should be addressed before we start treatment, especially the systemic therapies. Thank you, ma'am. So now we go to the last, and we have saved the best for the last. And we're having a little panel which will be on TNBC and more so of sequencing of the drugs, available agents, also the role of immunotherapy and lot more. And we have Dr. Vamsi Krishna, who's the Director of Medical Oncology for the AIG Institute of Oncology, Hyderabad, and the panelist Vinay Makka from Bangalore Ramaya Hospital. We have Rakesh Viniti, who is from Hyderabad. We have Kripa Shankar from Coimbatore and Nidhi Tandon, who is in the Narayan Health City, Bangalore. I think Ajit will not be there with us. Dr. Vamsi.
Good evening. And before I start, Dr. Sahu, how much time do I have? 20 minutes or what's the time?
25 to 30 minutes.
25 minutes. Okay, great. So let me just start by sharing my screen and maximizing it. So I hope these slides are visible.
Yeah, it is.
Fantastic. So I can see Dr. Vinayak, Dr. Rakesh, are you there? If you can switch on video, and Dr. Nidhi is there, and Dr. Krupa is also there. So let's start off with this case. It's a simple case, 50-year-old lady, perimenopausal, no family history, presenting with mild cough, mild class 1 NIHA, dyspnea. She admits after questioning that there has been a lump in the breast for the past 6 months, which has increased its size. Examination wise, still PS1, right breast examination showing a 5 into 6 centimeter lump with skin involvement, multiple axillary nodes, biopsy, IDC grade 2, triple negative, ERPR negative, HER2 negative, and PET CT scan done showing a breast lump with lung and bone mets which are more than 5 in number. So a pretty straightforward case, metastatic TNBC, right? So what next? Vinayak, starting with you, what next? What would you want to do in this patient? We'll take it for granted that we are going to give her zoledronic acid for her, bone metastasis. We'll take it for granted that we are doing ovarian suppression. If anyway, TNBC, we don't need to do that, but let's not get into those areas. Let's just talk of this case, the breast cancer management.
So assuming that it is metastatic TNBC de novo without any chemotherapy drug. Okay.
Your voice is a little faint, Dr. Vinayak. Yeah, if your speakers, yeah.
Can you hear me now?
Yeah, I can hear you now. Yes.
So assuming that it is metastatic TNBC upfront without any chemotherapy given, right?
Yes.
Correct.
Yes.
Yeah. So considering the goal for long-term thing, I would usually prefer a taxane-based regime first, chemotherapy. They had a questions also, so I'll take it.
Yes, I did. One by one, I'm bringing them in.
No problem.
So, do you do a PDL1 testing? Yes, no.
Not now, actually.
Not now. Rakesh? Yes, no.
Yeah, I would do the PDL1 test.
You would do the PDL1 testing. So you can answer the next one. Which test would you use?
Double to C3.
22C3. Okay, you would do a CPS with 22C3.
Yeah.
All right. Dr. Nidhi, your thoughts on this? PDL1, yes, no, and if yes, what test?
Similar to Rakesh, yes, and CPS.
Yes, and CPS by 22C3. Okay. Kripa?
So, hi, Vamshi, and I love the way you put up the slides.
Are you there?
Can you hear me? Hello? Can you hear me?
Yes. You can hear you. Yeah, I can hear you.
Yeah. Okay, I'm sure. So I love the way you put up the slide saying that more than 5 metastases ruling out oligometastatic disease. So good one. And so I would definitely do a PDL1 on the DACO 22.
Let us not have confusion.
Okay.
DACO 22 is perfect. Okay. Everyone wants to do the PDL1 testing. Anyone wants to do anything else? Rakesh, beyond PDL1, would you like to do something in an upfront TNBC nowadays?
Germline BRCA testing.
Germline BRCA testing. Okay. What about this NGS, CGP, which are really the whole fad or the fashion right now? For a TNBC, would you like to do it?
As of now, I'll stick to what has been proved to be useful, and I will stick to germline BRCA testing upfront in frontline setting.
Fantastic. Dr. Nidhi, any other thoughts? Would you want to plump for these fancy tests or a PDL1 and a BRCA?
Not for frontline. BRCA and PDL1.
Perfect. Vinayak, frontline only PDL1. You said no. What about BRCA? You would do it even, because we will discuss BRCA down the line, and remember, it's not as easy as it sounds. It's not as good as it sounds. So would you do BRCA now or would you do it later?
No, if she fits the criteria for BRCA testing, irrespective of TNBC, other thing going like.
He's a TNBC at 50 years of age.
Yeah, it's okay. If I not upfront, but definitely for some part of the time I will do it.
Not upfront, but some point of time. Okay, interesting. Great. So let's start off with the topic that Dr. Sahu has asked us to talk of, IO as well as the sequencing. So considering IO, first question, would you use IO at all? And second question after that, what IO would you recommend? So let me start this time with Dr. Krupa. Would you recommend IO in TNBC today? And if yes, what IO would you recommend?
So yeah, I think if somebody's got a PDL1 or CPS of more than 10 on the DACO 22C3 antibody, I would definitely look at using Pembro as well. Definitely not Atizo because that indication has been pulled down.
Okay, so definitely no Atizo.
No Atizo. Okay, yeah, so Pembro with the Pacli and Carbo would be my backbone.
With Pacli and Carbo.
Carbo, yeah.
Okay, that's an interesting question. Interesting answer. We'll talk about it. Okay, Nidhi, your thoughts.
So if PDL1 CPS is more than 10, then I would use a taxane with pembrolizumab. Okay. Otherwise, I would not be using an IO.
Okay. What about which taxane? NAB taxane or normal taxane?
Would prefer to choose nab-paclitaxel, considering there was some when we combined with atezolizumab, the DEXA given before the paclitaxel was found, considered to be one of the reasons for not achieving the endpoints. So though in pembrolizumab study, all paclitaxel, gem-carbo, everything was used as a partner to pembrolizumab, but I would prefer using nab-paclitaxel.
Okay, so Krupa says Atezo, you just forget about it, but you still want to follow some tenets of it because you feel that steroid usage is the issue. That's why you want to avoid it. Okay, Rakesh, what's your thought on it? What's your take on this whole steroid? Because again, in lung, we know that you can use a small steroid, nothing is going to happen. What do you think?
I think I would concur with Dr. Nidhish Madam's opinion, saying that there is a difference of only nab-paclitaxel between IM for 130 and 131. Maybe that is the reason why the trial failed. We don't know. We are speculating, but probably a steroid-avoiding chemotherapy, single-agent chemotherapy is good enough for me in frontline setting in combination with pembrolizumab if the CPS is more than 10.
Okay, Dr. Vinayak, you agree with this discussion? Atezo definitely out and only Pembro in the first line with any of the 3 drugs that were used.
Yeah, Pembro, I think data is there, but it's just science we're talking. I agree with and go with completely. That's not my practice.
It's only science you're talking here.
Yeah, so that's a choice, but I prefer nab-paclitaxel actually. I want to use taxane upfront if they can afford
pembrolizumab. Prefer over taxane.
Yeah, nab-paclitaxel. I think in my experience with TNBC with nab-paclitaxel has been reasonably well. Tolerance issues and as well as they do well actually.
Okay, they do well. All right. All right. So Dr. Bharat has told us that we should do with the specific platform. But since everyone is doing with Pembro, the specific platform is CT23. And Pembro both have shown the same PFS as with the Pacli and this thing. Okay. First, let's just go to Atezo. Now, the interesting thing, couple of points which I wanted to really highlight, the 130 using nab-pacli, the time interval was allowed was more than 12 months from a neoadjuvant and adjuvant setting. That is one aspect which I wanted to highlight. And then, of course, no crossover allowed in this study. Practically speaking, that's difficult, but no crossover allowed. And then you get this result wherein a PD-L1 positive patient, you're having a hazard ratio of 0.67 and a positive OS. Whereas in the I-130, in the IM-131, same group, using patients more than 12 months gap and no crossover allowed here as well with paclitaxel. In fact, if you look here, the paclitaxel dose is 90 per meter square, where we actually, conventionally use 80 per meter square. Despite that, your PFS did not show any benefit. The OS did not show any benefit. In fact, in the normal group, if you look, the overall PD-L1 positive population, the paclitaxel had an OS of 28 months, whereas the Atezo had an overall survival of only 22 months. So really difficult results. So Dr. Vinayak, how this discrepancy could have come across? You just think that the steroid alone, one single little steroid given and that caused all this huge difference between the IM passion 130, 131? Is it the nab-pacli which caused the difference? What's your thoughts?
Actually, I have no idea to explain this is just being honest.
Yeah.
But I do agree, comparing extrapolating from other trials where they done the nab-paclitaxel and see better outcomes compared to normal paclitaxel. We can assume that. And steroid in immunotherapy is a little bit, not much of thing is there. So I prefer, if a patient needs steroids, I would give. And I would prefer a regime which doesn't have steroid. Both are true actually.
Dr. Krupa, your thoughts on this? You said no Atezo at all, it has been pulled, but it's still approved in the NCCN. It is still approved by FDA that you can use Pembro Atezo with PD-L1 positive patient with nab-paclitaxel.
Yeah, I'll get to that, Vamshi. So the thing is, Roche has actually voluntarily withdrawn its indication from.
Yes.
So when a company themselves have actually voluntarily withdrawn its indication, I think that's good enough for us not to use it. Number one. And the other thing about the discrepancy, there's something I wanted to touch on. See, there's a lot of statistical jugglery with the IM Passion 130. If you look at the co-primary endpoints of OS and PFS, that was supposed to be positive in the overall intention to treat population. That did not happen. However, despite that not being happening, they went on and did a hierarchical testing in the PD-L1 positive subset. And with a lot of statistical jugglery, they were able to show that was significant, which to me was a major. I don't think that's how we should actually look at doing a trial. And I think that was one of the reasons as to why, why I always said ITSO again has to go down the drain.
Perfect. I completely agree with you. And this trend to worse OS with a paclitaxel in a PD-L1 positive group where you're supposed to have benefit, really, it's the final nail in the coffin. And I personally agree completely with you, Kripa. I think the discussion of ATIZO should stop in at least the first line TNBC. Pembrolizumab in TNBC now, again, some things which were interesting for me. Now, remember, I kept harping on the 12 months. Now, look in this study, they actually could use within 6 months of the recurrence. So, adjuvant or neoadjuvant chemotherapy should have been completed 6 months, not 12. So, you're in effect using a slightly worse population. Again, they looked at the primary endpoint. You talked about this. You had CPS more than 10, more than 1, and intent to treat. And again, the investigator's choice, nab-paclitaxel again at 90, and then a combination of gem and carbo. So that's different. You're having 2 single agents, and then you have a combination of the 2 drugs. And when you looked at the CPS more than 10 population, you had a significant PFS advantage that was seen, which was statistically significant here. When you looked at the more than 10 population according to subset, again, looking at the combination of the patients who have received prior neoadjuvant and the disease-free interval, it seems to work all the places. And this is what I wanted to highlight. The nab-paclitaxel gem-carbo group here, in the gem-carbo group, it is actually non-significant, 0.77, 8 versus 7.2. Among the 3 drugs, paclitaxel giving you a PFS of 3.6 months, nab-pacli 5.5, gem-carbo giving you 7.2 months. This was what they have again analyzed as per the chemotherapy regimen. And in all the 3 groups, when you had PD-L1 more than 1, PD-L1 more than 10, or intent to treat, everywhere this gem-carbo group, there is no benefit of giving pembrolizumab. So again, this is kind of visual thinking, just a kind of hypothesis generating. So Dr. Nidhi, first part of the doubt, early recurrences 6 to 12 months. Would you typically use taxane as one of the drugs as a comparator arm in that subgroup? I mean, normally we say at least 1 year should pass before you reuse the drug. So do you think in that 6 to 12 month taxane should be the right drug, considering that would have been used in your adjuvant and neoadjuvant setting?
So usually we do not use less than 6 to 12 months. Usually I do not use. Having said that, they have used in the trial.
To be honest, I could not find out how many patients actually did take taxane prior, and that number I could not find. So if somebody knows better than that, I'm happy to be educated on that. But yeah, go on. You were saying?
Yeah, the same thing. So usually less than 12 months, I do not use repeat taxane.
Okay. So the same thing, Dr. Vinayak. Could the benefit be actually due to the carboplatin that we added to the gemcitabine? That benefit that we are getting, because when you add gem to carbo, the pembro doesn't seem to be doing anything in the PFS at least.
It's a heterogeneous crowd of TNBC. You need to refine more, but I think definitely there is a benefit of adding carboplatin. Always, single agent gemcitabine is ineffective. That's what I'm trying to tell, because whoever used the breast patients with gemcitabine, they know that it doesn't work single agent. So you need to add carboplatin. And I agree with Nidhi that taxane failure that's what important actually. If your post-adjuvant failure is there, my preference is usually erbilene, but that's a different story. But because most of patients issues are non-science back thing, but definitely I would not use taxane if it is early recurrence.
So Rakesh, your thoughts on all these? These are small issues, but did that really make pembro succeed where probably the ATIZO failed? And what's your thought? How come this pembro worked and that didn't work? So that's really something.
Sir, I think you're trying to infer that it was an inferior chemotherapy backbone, the placebo arm.
I'm just asking, it's just a thought.
Actually work for the pembro.
It's a thought.
I think there is the debate of combination versus single agent in the triple-negative breast cancer metastatic disease is there. I think we are justified to use a combination when there are patients who are very symptomatic, and especially where there are a lot more visceral metastases. I think there's a bias of using carboplatin in those patients, and probably the bias is carried into this trial as well. but I don't think so carbo has any significantly contributed to the better outcomes.
Okay. You think it is still the Pembro which is doing the job? Okay, fair enough.
Yes.
Okay.
Yes.
Next question really is what level of PD-L1 is needed? And again, I'm asking this because when you start looking at, this is not the original trial, this is the 119, which is in second line. And they found that the best results were actually seen when you had PD-L1 more than 20 rather than actually 10. You know, the more the PD-L1, the merrier. So whether if we had used the PD-L1 more than 20, we would have had less patients, but even better results. Again, a thought-provoking question, just a hypothesis generator. So I think that's about the endpoint of the IO trials. And I think all my panel would kind of lean to using pembrolizumab in first line for all patients. Is that correct? I mean, of course, academics funding apart. Is that a fair assumption to make for everybody?
Yes.
Okay, perfect. So coming to PARP inhibitors now, everyone said they would routinely test germline BRCA. Would anyone also test for the HRD? And
so Vamsi, so is it that the panel is suggesting that they are in favor of using a Pembro for all TNBCs irrespective of the CPS score?
No, everyone has clarified that.
I don't think so, sir. I think we are
10.
CPS
Okay.
more than 10 has been what all panelists have specifically said. Yes.
Yeah.
Yes.
So is it this last slide which you showed, and most of us patients are paying out of the pocket, and even if it's a reimbursement, this one.
Yeah.
This does tell me that the more than 10 story is actually driven by more than 20.
So again, this is not.
No, this is a different trial.
This is a different trial. This is not from that. This is a second line trial.
Yeah. So do we have any data from the 355 for the beyond more than 20?
I couldn't find it. It might be there, but I couldn't find it. So again, that the reason I put it up just to say that, okay, are we being putting our trust a little lower, and whether we should put it just a yes.
Sir, it is there, sir. Sir, less than 1 to 9, nothing. 10 to 19 hazard ratio is 0.71, and more than 20 the hazard ratio is 0.72. In terms of quantum of benefit, 20 months in 1 to 19 and 24 months OS in more than 20. That has been given.
In 355.
So more than
one more point I would like to make.
19 also the hazard ratio is 0.71.
Okay, I have only 5 minutes more to cover a couple of more things. So can we just move on with this? Right. So testing for I think everyone wants to test for routinely BRCA. And this is really my question. The Olympia trial does not show an OS benefit. The trial tested in the maintenance regimen. So Vinayak, would you still want to test BRCA, and where would you like to actually use a PARP inhibitor in this setting?
See, the first thing is I want to finish off the chemotherapy, which has survival benefit. I want to finish eribulin. Let me be very honest, and that is.
You will finish eribulin first. You want survival benefit.
Yeah, I want that benefit first, and then if pembrolizumab will even see, this is just my guess. Eventually, it will also show not just like other withdrawal happen. It will happen because it has not been vetted. So if you say the chemotherapy arms, if 3 arms, it was not powered to see which chemotherapy arm is better for pembrolizumab.
Fair enough. Agree. I agree with that.
I mean, as of data is there, we can offer patients, and it's at the CPC 10. Patients who can afford, most of our practice will not be, but definitely will offer. But we should never let go of the chemotherapy arms. We finish off all the chemotherapy.
Sure.
And when we will do a test early, so that once you do finish chemotherapy, some kind of maintenance we can put PARP inhibitor. Wherever is possible.
Is not shown an overall survival benefit. Are you still okay with that? That's my question.
As of now, yeah, I am okay with it as long as there is like clear-cut mutation is there. There is heterogeneous crowd even in the PARP thing. I understand that, and I try to give benefit of doubt and use it off.
Okay, so Rakesh, do you agree with this? Rather than leaving on observation, just because you do have a BRCA, give it even though it has still not shown an overall survival benefit, if I can understand that correctly.
And with residual disease, okay?
With risk. Okay, Rakesh. Dr. Rakesh, can you hear me?
So I think, yes, sir, I'm here. So I think the frontline testing for germline, and if the patient is BRCA mutant, there is enough reasons to add a single agent olaparib, and I would prefer to use olaparib compared to that single agent chemotherapy. I think the PFS benefit is there, and it's a matter of time we get educated about the overall survival benefit also.
Negative.
But obviously, it is going to be a crossover, and there will be a lot of dilution of the results.
Okay. Kripa, do you agree with this?
But I think there is a lot of dilution because of the crossover, and all those things will be there.
Okay. Dr. Kripa,
So,
do you agree with this?
Yeah, no, I don't, because like you rightly showed, I think despite this trial not allowing for crossover, they were not able to show an overall survival advantage, which I think is probably the final nail in the coffin. It's only showed a doubling of PFS, and that to an absolute PFS benefit of 3.5 months. So no OS, despite not allowing for crossover. Control arm did not allow for platinum as well. Treatment of physician choice did not have a platinum. It was just gemcitabine and capecitabine. So I think those are my reservations. Definitely not in the first line nor in the second line. Maybe third line onwards, especially if somebody's got a germline BRCA.
What about this combination? You know, the Medulla trial, small trial, showed a combination and showed that ORR was 63% and you had an OS of 21 months.
Yeah, that seems to be really promising because we've seen the same sort of data in platinum-resistant ovarian cancer as well, where they're looking at the same combination of IO plus PARP inhibitors. The rationale seems to be interesting because when we use the PARP inhibitors, we know that the DNA, repair mechanisms are going to result in higher tumor mutational burden and new antigenal load goes up. That way, making the immunotherapy, much better conducive environment for immune checkpoint inhibitors to work. So the rationale is there, the hypothesis is there. But I think we'll have to wait for the data to be more mature until we have phase 3 data. So,
Dr. Nidhi, your thoughts on this? Everyone said we'll check BRCA, and honestly, even when you don't look at this data, this is kind of a knee-jerk reaction. TNBC checked BRCA and give olaparib. It didn't show us advantage. Well, maybe you should wait for the talazoparib and other things. Maybe that will show us the advantage. But what's your thoughts on this?
Yes. Even if germline BRCA is mutated, then also I would prefer to use chemotherapy first and reserve olaparib for the later lines.
Okay, fair enough. So let's come to real world. I think 90% or 95% of patients will never go for an immunotherapy. What do we routinely do in the first line? I'll not ask Vinay because he has already declared he'll give Eribulin. So Dr. Rakesh, your thought, would you prefer a combination with carboplatin or a second line as carboplatin and keep using it as single agent? What's your usual practice?
So I would routinely use a single agent chemotherapy if patient is very symptomatic, result crisis, or some sort of response is needed, probably a combination with carboplatin. And again, single agent chemotherapy, non-cross tolerant drugs. Next.
Fair enough. Dr. Nidhi, from TMH, metronomic chemotherapy, your thoughts? Do you use it in practice?
Yes, I do tend to use it in practice, especially when the patient wants a IV chemo-free interval.
What do you use? What is the drug you are using?
Capecitabine based largely. So,
all right, great. So I think anyone who has gone in through that has this DNA imbued with metronomic at some level, though we do try different combinations, but I take your point, it should be one of the options. Krupa, Satusumab, Govatican, purely academic discussion. Any personal experience, number one, and secondly, where do you place Satusumab, Govatican today in the treatment?
Yeah, so this is the Ascent data that we're talking about here, which led to the approval of this drug. So post 2 lines of therapy, and to be frank, I've never had an opportunity to use this drug until now. But if you look at it, it's approved post 2 lines, and that's where I would place it as well. In the metastatic setting, post 2 lines of therapy is where I would look at doing it. And
perfect. Dr. Rakesh, Dr. Vinayak, Nidhi, any personal use of this drug?
Not used as yet.
So this is the Ascent data that very rightly pointed out by Krupa, and again, drug conjugate. And in this, again, the analysis was there in the comparator arm, which did not actually include many of the other commonly used drugs. So it seems to be a drug which works, and let's see how it goes in the future. When you actually use the other treatment of physician choice, it's interesting to note that they use capecitabine, eribulin, gemcitabine, or vinorelbine. We really don't know how many of them had taxanes and why taxane was not one of the drugs used here. So that is an interesting question which really needs to be answered, and we don't have the answer to that. Again, you could include patients who progress within 12 months of neoadjuvant and could use prior taxane. So taxane rechallenge is one of the options in this, but this trial did not allow that. Again, I'm not sure that's the reason not to use this drug. Second interesting thing is PFS by BICR in patients without brain mets. So that's their endpoint. It is not overall survival, not PFS. So just trying to be a little bit of a thing. Right. Second line IO, quick question. We are already out of time as per Dr. Sahu. So just one thing, Dr. Rakesh, second line, would you use IO or not? If not used in the first line?
No,
Again,
sir.
I put up the data here.
Probably, not probably.
Yeah, I mean, look at this. The ORR is only 10 to 15%.
I have not used it before.
No, the PFS is hardly 2 to 2.5 months in all the studies, ORR of 10 to 15. And the interesting part was the enhanced one, Dr. Vinayak. This was the combination of Pembro with eribulin. And they used it in 106 patients. ORR increased to 26%. So possibly, combining eribulin, which is your favorite, with Pembro seems to be a better option than doing other things. Finally, Dr. Nidhi and then Dr. Krupa, HER2 low in TNBC. Would you now go back and say, okay, HER2 is 1+ or it is 2+ and FISH negative? What's your thoughts on the TXD in a TNBC setting? Dr. Krupa.
I think, yeah, we've seen promising results, especially in the HER2 low subsets and on trastuzumab deruxtecan. But I think, we're not yet ready for prime time in TNBC.
Okay.
I think we'll probably have to wait for some of the data to be mature, especially in the TNBC subsets. I think that's probably how I would put it.
Dr. Nidhi, your thoughts on this? I mean, let me be honest, Twitter is talking only about this in the last 10 days, and post-ASCO, this is one of the practice changes which people are going to make as per the Western oncologists. This is a practice change for them. Do you agree with this? What's your thought? You would want to wait and watch?
I would just second Dr. Krupa. Promising, but too soon to say.
Okay. I kind of tend to agree with more because of the cost of the medicine, and it completely changes our entire concept of what breast cancer is all about. So this is the exploratory analysis, and what it showed is that there's an OS advantage in both the TNBC group in the HER2 negative group. So this is around 10% of the total population. Even there, you have a PFS and an OS advantage. So, it seems to work in both the cases. So for me, there are plenty of unanswered questions still in TNBC. Importantly, with the IO shifting to neoadjuvant, what do we do? Any takers for low dose IO? I think that's where all Indian oncologists are very, very interested and excited to read. So plenty more questions, and if there are no other comments from the panel.
Two things. The point of POPs, which I wanted to ask from panel, is for them, as I heard it is out of their schemata of things. Because if you look at the Embraca, which is talazoparib, and the Olympia, which is the olaparib, they have used it in earlier lines. Yeah. If for olaparib, it was less than 2, and for talazo, it was less than 3, and 80% patients were actually no chemotherapy at all, or one chemotherapy. So the point which I get it from is, if you're using POPs, it is upfront, maybe in the early lines, 1 or 0. Later on, there is no much data, or is olaparib or POPs out of TNBC? Point number 1. Point number 2, HER2 low, the data which is now come from Destiny 4. 1 and 2, can anyone tell me how much of the triple negative is the 0 is 1 and 2? How many are 0 and how many 1 and 2? What percentage?
So all the patients in TDXD are either HER1 or 2+.
Yeah, so I understand that. Yeah.
I'm not sure, because total TNBC is 10%.
So now will this comes in, keep the cost apart. So are we pushing the immunotherapy back on a backseat? Is again which I wanted to ask. Or is it immunotherapy frontline? Number 1.
So TDXD is not in the first line.
Agreed.
Yeah, TDXD was the Destiny breast was actually in the patients who have already received 1 to 2 lines of
1 line. Yeah.
It's not the first. It's second or third line.
So how many received immunotherapy? Is there any data on that, MC?
I did not find it because I couldn't find the full paper. I have gone through only the abstract. Okay. Maybe the full paper supplement might have it.
So can you answer the POP thing for me? For the way I get it, if you don't do it early, it's a gone drug.
It's a failed drug.
How, sir, can I come in? Yes. Just one thing. Nice. If you extrapolate from ovary, what has happened in second line and beyond, the PARP are not so great when compared to use as first line maintenance. And biology being same, I agree with you, but I don't think it can go alone. There are a lot of combination therapies with PARP is happening in ovary also. All the immunotherapy and a lot of other newer drugs. I think standalone PARP will not give that results upfront. That's there. So you have to have.
I would disagree. I would say that there is data today in 2022 that PARP in first line works in germline BRCA mutant patients. It may not show overall survival benefits at the end because there will be patients using it at subsequent point of time. I think we have the best benefit of using PARP inhibitors in frontline setting. There is no other data that is out there.
So that's what Dr. Sahu has been basically saying. So I think this discussion is not yet over. The Olympiad was negative, but I think the Embraca is going to come up somewhere positive, and we need to
And
see.
the Embraca is out. Embraca is out already, and they're saying the same thing. The PFS is positive, the OS is not
OS
there.
is negative. Okay. So
No, if
then
I can
we
probably
need to wait
quickly
for the
chip in.
rucaparib data and the other data, because the
If I can
rucaparib and niraparib are also due.
Kripa, something.
Yeah. So I mean, like, there's another study called the Brocade study, which has looked at veliparib plus paclitaxel as well. So even in that, unfortunately, that wasn't statistically significant, the primary endpoint. So I mean, like, you can read a lot into it, but unfortunately, I'm not a huge fan of using it right up front. Probably post 1 line or at least 2 lines is how I would look at it. And like you rightly pointed out, Sauser, post 2 lines, Embraca study did allow for patients even post 2 lines. So I think, fair enough. I think horses for courses. If somebody's got a high PDL1 CPS more than 10, definitely go ahead with immune checkpoint inhibitors in the first line.
So on that note, I think you can ask experience of people. I have used PARP inhibitor in TNBC with BRCA positive more than 5 patients. None of the patient pulled more than 4 months. That's just my personal experience.
This was a later line or front line?
It was second line and beyond, but
That's what when you say first line, are you meaning without any chemo, anything, just use only?
Yeah. That's what it is. If you look at the Embraca, 35% were no chemotherapy at all, and 35 was
Okay. The Olympiad is a maintenance. So you're saying no chemo, just start off directly or only single agent, and that's where it works.
No prior cytotoxic for advanced breast cancer for the Embraca was 40%, and 38% was only one chemotherapy. So basically, what I say, every trial, even what Krupa told about the veliparib and addition of chemo, again the same thing. I don't know. This is something very different and typical of breast cancers, and that is what is showing the same trend. Even the Brocade 3, which Kripa told, if I'm right, there was a difference in PFS again. No OS benefit.
So veliparib is very mixed data. It didn't work in the neoadjuvant as well when you looked at the brightness. So I'm not sure veliparib again is a great PARP inhibitor in itself. So that's there.
Yeah, even the data from the SWOG for veli and cis versus cis, it did not show benefit, the addition of veliparib.
So anyway, I think it is now it's around 9:40. We have exceeded our time by 10 minutes. So thank you, Dr. Sahu, for allowing us that. And fascinating discussion as always.
Thank you, MC. And thank you especially for doing it at a place where you are away from your home. And thank you for agreeing to it in the last moment. And I think this point of sequencing is going to get more complicated, as I am very sure that EDX is going to move frontline in the HER2 new low. And once it comes frontline, then it's going to get more confusion of where to put the immunotherapy things and the sequencing, the govitecan and other things. So that's why I think we'll have more such panels, and non-pharma panels will be the best way to pull out the best experience for all of us. Thank you, Vansi. Thank you, panelists. I have the privilege of going for the conclusion comments. And Dr. Naresh, you're there? No. So if Dr. Naresh is not there, so I'll do it for the team. Thank you, all the faculty, for being there, and I thank most of them for being telling me okay with one phone call. And thank you all the panelists, thank you all the speakers, the debaters. It was lovely, and I learned a lot pulling out data to make this agenda, and I learned a lot being there for 3 hours in this meeting. Thank you, the back team, for supporting us, Tarun, Survi, and the whole team. Actually, if I've left out someone's name, I'm sorry for that. And I would just like to thank Naresh for keeping confidence upon me to doing this and pulling this out. I hope we have done a decent job. We had tried not to be repetitive. We didn't try to do something which has been doing always on and on. Thank you, all of you, and stay safe. COVID is making a little bit surge. Nothing much to worry with. That's what I feel. But we all have to mask up and maintain all COVID safety rules. And thank you again. Good night, and let's meet somewhere. Hope so physically very soon. Thank you.
So thank you so very much, Dr. Sahu, for such a brilliant show. So thank you so much for your efforts, and everyone. So from all of us from the organizing committee, stay safe. Good night. Have a nice weekend.